Hi, those of you who don't know me, I'm Shyam Varadarajulu. So I'm from the Digestive Health Institute. So this program has been instituted for the last 4 years. And then for those of us who practice in this area, we know GA is managed by nurse practitioners. You are the most important partners for gastroenterologists. As we just go and do our procedures, you are the ones who see the patients on a daily basis and communicate with us. So we felt we should organize this for the APPs from this area because we know how valuable you are. And for those of you who don't know us, we've been in Orlando Health for the last 3 years. It's a brand new group. It was founded in January of 2022. And we are a group of about 30 gastroenterologists. And we have about 27 nurse practitioners. So it's a 60-member team. We cover about 5 hospitals. This is a group that is not only involved with clinical care of patients. We see a lot of patients in the clinic. So in 3 years, we have built our volume. We see about 5,000 patients in the clinics each month. And we do about 50,000 patients in the outpatients in the hospital setting, about 45,000 inpatients, and close to 10,000 patients in the AECs. So it's not very big, but it's a growing program. And we have a new liver program that's been there for about 2 years. And we have recruited the second hepatologist. They see about 400 patients each month. And so is IBD. We have the largest IBD program in Central Florida. There are 2 full-time doctors practicing IBD. They do excellent clinical trials and provide excellent care for their patients. We are also one among the very few centers in the country that has a medical pancreatologist. Dr. Mel Wilcox, who used to be the chief of gastroenterology at UAB, runs this program. We also have a very active motility program. One motility doctor who's very busy. So that's why you see this spike. When he takes a vacation, the graph goes down. But he sees about 400 patients each month. And we are trying to add to the group, but that's one recruitment that's always difficult. And I perform advanced endoscopy. So we have, in the last 3 years, this year, we have done about we'll perform close to 10,500 advanced procedures. We are the largest endoscopic ultrasound center in the nation. We perform close to 4,000 procedures. But most importantly, we do a lot of clinical research. A majority of what we do is endoscopic ultrasound. This is not just a Central Florida-based program. You can see that our referral base actually is the lowest within the Tri-County area, and a majority of our referrals come from as far as Tallahassee and Pensacola and Panama City, and a large number of patients also started coming from Alabama. So we draw from the southern states with about more than 1,000 patients outside the Tri-County. Metrics is very important, and if you go to our website, you will see the outcomes. So the orange line is the national average. You can see that when it comes to quality outcomes in colonoscopy, we are significantly more than what is prescribed by our societies. And the same is true for advanced endoscopy. Our success rate is more than 99% with an adverse event of less than 1%, significantly higher than the national average. This is something that we are very proud of. This is not a community-based practice. We conduct some of the best clinical trials in the United States, and we publish the largest in pancreatic and biliary diseases in endoscopy. So these are published in Gut and Lancet sometime this year. And we have also developed protocols for management of stones and pancreatitis named after the city in which we practice. We just recently concluded our randomized trial comparing endoscopy and surgery for gastrojejunostomy in pancreatic cancer. Hopefully we will have this paper submitted to the New England Journal pretty fast. Another thing that is very unique to our program is artificial intelligence and EUS. This is something that was developed by us in collaboration with our colleagues in Europe, and we are the only center in the world who have integrated artificial intelligence within endoscopic ultrasound. And this is a research that has been completed, and it is integrated in our daily clinical practice. We are also founded a group called the United States Pancreatic Disease Study Group. You will see all the top 50 academic centers in the nation as part of this enterprise, and we run this group with Dr. Wilcox. And this will be the first research trial comparing sham treatment versus celiac plexus block for management of chronic pancreatitis in this patient population. We also have an extracorporeal shockwave lithotripsy, making us one among the only 3 centers in the country in which the technology is integrated within the clinical practice. And this is not the machine that is usually used by urologists for fragmenting pancreatic stones, but this is dedicated specifically for use of patients with chronic calcific pancreatitis. This is also a very academically strong program. We started a gastroenterology fellowship last year. The second batch of fellows will come this next July. We also have an advanced endoscopy fellowship. and mostly these are folks who come from international gastroenterologists who come for a year and then they go back. The two top textbooks in gastroenterology in the world actually come out of Orlando Health. Schlesinger owns 99% of the market share of all gastroenterologists in the world for whom it's prescribed, and endosonography is a book that close to 99% of all EUS people in the world read, and both textbooks come out of the same institution. This is our signature conference, our live endoscopy. It draws delegates as far as New Zealand, all the way to every part of North America. So we bring delegates from about 30 countries. A majority of them are international. And this is your meeting today that we'll be having over the next 2 days, where we have participation from close to 20 states. So this is the milestones that we have established for ourselves. We are already in 2024, the third year. It was quite an ambitious goal. We wanted within the 3-year time frame to be the best EUS center in the nation. We are there. We are within the top 5 EUS endoscopy programs in the country by volume and by research. We have completed 5 randomized trials. We wanted to publish at least 30 papers in the 3 years we'll be here. But actually, we're close to 50, and we have met all of our goals that we had, with the exception of liver transplantation. So liver transplantation will be started within the system, hopefully within the next few years. But this program is for you. I hope you will find this afternoon session very useful. We have mostly colleagues from Orlando Health, and one of my former colleagues from UAB will be here to speak to you about a few topics. We have kept it as practical as possible. We have updated the syllabus book. It's not the same syllabus book that we made last year. We have tried to make it friendly. We will also try to put it in an app so that you don't have to carry the book with you. Feel free to ask any questions that you want. This is an informal group. We know most of you in this group. There's going to be an audience poll. This is just a self-assessment. So you have to scan the QR code. We will wait for the questions so that your answers can be polled and you will have it. I hope you will also come tomorrow and spend the next 2 days with us. But most importantly, you can stop by anytime to any of our campuses to see us practice if you want to spend a few days with our program. But I want to welcome you again for this program and thank all the vendors who are supporting this conference, without whom this is not possible. So I'm going to have Mitali Agarwal, who's my colleague in inflammatory bowel disease unit. She's now going to provide the first talk on management of diarrhea. Mitali.
Thank you all for coming and joining us today. I hope that you gained something from my talk. Before I begin, I'd like to thank Dr. V for inviting me back a second time to give this talk. So maybe that means he liked my talk from last year. That's why he invited me back. So without further ado, let's go ahead and talk a little bit about diarrhea today. So the objectives of today's talk is to first define what diarrhea is, define it based on whether acute or chronic, develop a rational approach towards evaluating patients with diarrhea, review elusive causes of diarrhea, and then briefly touch upon how we would manage these patients. So before we define what diarrhea is, it's important for us to understand what normal bowel movements are in patients. And we should understand that the average number of bowel movements is very variable in healthy individuals. So the spectrum of frequency that is considered normal can be anywhere from 1 bowel movement every 3 days to 3 bowel movements daily. Diarrhea comes from the Greek terms dia, which means through, and rein, which means to flow. And medically speaking, it's defined as having over 200 grams of stool in 24 hours. But that's a very impractical definition because we can't really ask our patients to measure the volume of stool they're having in 24 hours. So a more practical definition for diarrhea is having more than 3 bowel movements in 24 hours with a change in stool consistency to anywhere between watery and loose. This is Bristol type 5 to 7, and we'll go over the Bristol chart in the next slide. 2 things I do want to point out is something called pseudo-diarrhea or hyperdefecation. This is when patients have an increase in stool frequency, but the weight of the stool is less than 200 grams, and there's no change in stool consistency. This is typically seen in patients with irritable bowel syndrome. There's also something called fecal incontinence, which is an involuntary release of rectal contents, and that can be due to a motility issue, due to problems with nerves and muscles that innervate the rectum. We're not going to focus on these two topics today. So this is the Bristol stool chart, and it ranges from type 1 to type 7. Type 1 to 3 are patients that are more constipated, where they're having hard, more pellet-like stool. And types 5 to 7 are patients that are having more diarrhea, where the stool is more loose and watery. Type 4 is the ideal patient that is having more formed stool. What we would look for is something like a sausage or a snake-like consistency. So going on to a few more definitions. So what is acute diarrhea? Acute diarrhea is diarrhea that lasts less than 14 days. Typically, it's infectious in origin, but it can also occur if patients have eaten something or started a new medication. It usually does not require treatment, it's self-limited, and usually does not require extensive evaluation. Persistent diarrhea is diarrhea that lasts from 14 to 30 days. And then chronic diarrhea is diarrhea that lasts more than 1 month. Chronic diarrhea has a large differential. It can occur due to functional disorders, autoimmune disorders like inflammatory bowel disease or celiac disease. It can be due to malabsorption, medication-induced, ischemia, cancer, or even chronic infections. You can distinguish the type of diarrhea a patient is having based on whether it's osmotic or secretory, and we'll go over that in the next upcoming slides. So there are 5 major mechanisms by which patients experience diarrhea. Number 1 is through an increased osmotic load within the GI tract lumen. Number 2 is via increased secretion of electrolytes within the GI tract lumen. We'll define that more coming up. You can also get diarrhea if there's a decrease in normal intestinal absorption, inflammation of the intestinal lining, such as patients that have inflammatory bowel disease, or patients that have abnormal intestinal motility. So I talked to you guys briefly in the preceding slides about osmotic diarrhea, and now I'm going to define it for you. So osmotic diarrhea occurs when there is an osmotic agent that's soluble in water and it's present within the GI tract lumen, but this osmotic agent cannot be absorbed by the GI tract lumen and thus creates an osmotic gradient. This osmotic gradient then draws water from the intestinal lumen, from the intestinal fluid, and that results in diarrhea. The stool is moderately increased in volume. This type of diarrhea usually occurs because patients are taking some sort of exogenous agent, such as laxatives like polyethylene glycol, or artificial sweeteners such as sorbitol or mannitol. So when patients are fasting or they stop these exogenous agents, this type of diarrhea generally resolves. The next type of diarrhea is secretory diarrhea. Now, this type of diarrhea occurs because there's a dysfunction at the cellular level of the intestinal lumen, affecting the sodium-potassium chloride pump. So in this type of diarrhea, the chloride is actively secreted into the intestinal lumen, and what results is water follows the chloride into the intestinal lumen, and this results in diarrhea. This type of diarrhea tends to be very profound and large amount. And this type of diarrhea does not improve with patients fasting because it's nothing that they are exogenously taking. It's a dysfunction at the intestinal cellular level. This type of diarrhea usually occurs due to certain toxins like heavy metals or even toxins from bacteria from Vibrio cholerae or E. coli. Certain hormone-producing tumors like vipioma, gastrinoma, or mastocytosis can also result in secretory diarrhea. So how you can determine whether a patient is having osmotic or secretory diarrhea is by calculating the stool osmotic gap. So you would have to get the stool electrolytes, particularly stool sodium and potassium, and plug it into this equation. When the stool osmotic gap is less than 50, it is due to secretory diarrhea, and when it's more than 125, it is due to osmotic diarrhea. So what is my approach to managing patients with diarrhea? My clinic is basically filled with patients that come in complaining of diarrhea all the time, whether it's due to inflammatory bowel disease or some other cause that primary care or other providers are not able to elucidate the cause. So history taking is very important. We must have a really good understanding of their medications, if they've recently been on antibiotics, if they take PPIs, SSRIs, or NSAIDs, or laxatives. PPIs, SSRI, NSAIDs have been known to be a potential worsening risk factor for diarrhea in patients with microscopic colitis. It's also important to get a good dietary history if patients are taking artificial sweeteners. Like I mentioned, sorbitol can cause diarrhea. Family history is important as well to see if they have any underlying autoimmune family history, because these conditions tend to run in families as there is a genetic component. Surgical history is also important to see if they've had their gallbladder taken out or if they've had resection of their terminal ileum, both of which can result in bile acid malabsorption. Travel history, diet history, work history, past medical history, and also getting an understanding of some associated symptoms, whether they're having pain, weight loss, blood in their stool, and then duration of symptoms, so you can decide whether it's more of an acute picture or more of a chronic picture. Description of the stool is also very important. If patients are complaining of bloody diarrhea, you tend to think of invasive organisms such as E. coli causing the type of diarrhea, or inflammatory bowel disease, particularly affecting the colon. You also tend to think of ischemia or malignancy. When patients complain of more watery diarrhea, you tend to think of the disease affecting more of the small bowel. If patients complain of a sense of incomplete evacuation or a sense of urgency, you do tend to think of a more rectal disease. And then when patients say that, hey doc, I have some sort of fat droplets that are floating on the toilet bowl, that's more of a fatty type diarrhea, you tend to think of a malabsorptive or a pancreatico-biliary dysfunction. The next couple slides are management of acute diarrhea. These are taken from the ACG guidelines from 2016. They are a little bit dated, but I still think they're pretty valid for today. So according to ACG, acute diarrhea is one of the leading causes of outpatient visits, hospitalization, and loss of quality of life. It's a major public health issue with over 50 million cases occurring annually and costs us over 150 million in healthcare costs. When it's infectious in origin, it can lead to chronic health sequelae such as post-infectious IBS, reactive arthritis, hemolytic uremic syndrome, or even Guillain-Barré syndrome. Generally, as I mentioned, in acute diarrhea, you do not need to have comprehensive laboratory evaluation because it lasts less than 14 days. It's generally viral in origin and generally tends to self-resolve. Getting an extensive evaluation is not practical, nor is it cost-effective in most patients. However, you must consider an evaluation in patients who work and handle food, are healthcare workers, daycare attendees and employees, and residents of institutional facilities. I'm a little biased on the next thing. I practice inflammatory bowel disease, so I also feel that patients that have underlying inflammatory bowel disease do warrant a little bit more extensive evaluation when they have new onset diarrhea. And lastly, evaluation is recommended when the symptoms are persistent, they're moderate to severe, there's blood present. So how do we treat acute diarrhea? In general, oral rehydration is what is recommended, with a rehydration solution containing water and a balanced electrolytes. You can tell your patients to make a homemade mixture with clean water, salt, and sugar, and there's plenty of recipes available online. You can look up the World Health Organization oral rehydration recipe. It's very cheap. It doesn't taste good, but it's easily available. Other options would be low sugar Gatorades like Gatorade 2 or Gatorade Zero. And other options are soups, juices, and some crackers. The use of pre and probiotics is generally not recommended for treatment of acute diarrhea. For symptom control, you can consider bismuth salicylate and loperamide in mild to moderate disease. Do not use empiric antibiotics for routine cases because, like I mentioned, most of the cases are due to virus, and so the antibiotic really is not going to shorten the duration of symptoms or help the patient, and may actually cause other problems such as C. diff or antibiotic resistance. In patients that have E. coli with Shiga toxin present, the use of antibiotics is not recommended because it can precipitate hemolytic uremic syndrome. However, in patients that are having more severe illness with fever, and it's travel associated, or if they have underlying inflammatory bowel disease, you can consider treating them. The recommended treatment is azithromycin 1 milligram single dose or 500 milligrams for 3 days. This is just a summary of the last 2 slides that I will leave for you all to review on your own just for the sake of time, but it's basically a summary of what I just mentioned. Now we'll sort of switch gears and talk about chronic diarrhea. We, in the preceding slides, discussed a number of causes that can cause chronic diarrhea, but in general, most often it's due to irritable bowel syndrome. Again, history taking is very important, understanding their medications, surgeries, travel, diet, family history, etc., and characterizing the type of diarrhea it is, whether it's watery, bloody, secretory, osmotic, fatty. That will help kind of narrow down your differential. Evaluation is recommended in patients that have chronic diarrhea after the age of 50, blood in their stools, nocturnal bowel movement. So nocturnal bowel movement is very important to define what it is. So patients will get up at night and they'll urinate and then they'll have a bowel movement. That's not really considered nocturnal bowel movement. Nocturnal bowel movement is something that wakes up a patient from their deep sleep to have particularly a bowel movement. That's not normal, so these patients require further evaluation. Other things are progressive abdominal pain, unexplained weight loss or fever, lab abnormalities such as iron deficiency, elevated CRP, elevated fecal calprotectin, and especially in patients with a family history of GI tract malignancy or IBD. My approach to patients with chronic diarrhea, I start off with just some routine blood work with CBC, CMP, checking their thyroid function, checking celiac serology. We can also check Giardia as well, and the AGA recommends checking a Giardia stool antigen plus nucleic acid detection, as that's a little bit more sensitive than just a typical ova and parasite. And actually, the AGA does not recommend getting ova and parasites in most patients because the incidence of parasites in the United States is very low unless the patient has traveled to a region that's endemic to parasitic disease or has recently immigrated from that region. Other tests that I get are fecal calprotectin and stool electrolytes to calculate the stool osmotic gap. You may want to consider imaging if diarrhea is accompanied by abdominal pain, fever, weight loss, just to evaluate the pancreas and the lining of the colon and small bowel. You may want to consider endoscopy with biopsy if alarm features are present and you want to rule out IBD, or if the celiac serologies are positive. SIBO breath testing is another consideration. Once all this testing has been done, then you can consider looking for elusive causes by checking serum gastrin levels, urine serotonin levels to check for more elusive causes like gastrinoma or serotonin or carcinoid. And then again, cannot emphasize this enough, check the medication history, make sure there's no laxative abuse. If a patient is taking laxatives, when we do endoscopy or colonoscopy on these patients, sometimes we'll look and find something called melanosis coli, which is basically tiny little black or dark spots that come up in the colon or small intestine. And that gives us an idea that maybe the patient is on senna or some sort of laxative. So management of chronic diarrhea, it's very variable. You have to treat the underlying etiology, so that's why it's important to figure out why the patient is having the diarrhea. If you can't really figure out the underlying etiology, it may be reasonable to treat patients for SIBO in patients that have risk factors, such as inflammatory bowel disease or extensive GI tract surgical resection. You can consider dairy restriction. You can consider a trial of cholestyramine or cholestyramine, which are bile acid sequestrants in patients that have had less than 100 centimeters of ileal resection or if they've had a cholecystectomy. And if all else fails, sometimes you can give them loperamide to see if that helps their symptoms. So in conclusion, diarrhea is defined as having over 200 grams of stool in 24 hours. However, a more practical definition is having more than 3 watery to loose bowel movements in a period of 24 hours. History taking is very important, understanding the duration of symptoms, description of stool, calculating an osmotic gap, and checking their medication history. Acute diarrhea is generally self-limited. It does not generally require treatment or extensive evaluation. In patients that are having more persistent or chronic diarrhea, you can consider checking calprotectin, giardia, celiac disease, evaluating for IBD, and then of course consider imaging and endoscopy in anybody with alarm symptoms. So I'll conclude by asking one question. We have a 72-year-old female with history of diabetes and hypertension who presents to you for evaluation of diarrhea, abdominal discomfort, and bloating. Her prior work includes a normal CBC, CMP, celiac serologies while eating gluten. Her stool studies for infection were normal. She empirically put herself on a gluten-free diet, but that has not helped her symptoms. She presents to you in clinic. What would be the next step you would consider?
Can we go back? That will give people some time to look at that. Okay, can you go back on that slide?
Yeah, I think.
Okay, good. And you can do the polling now. Okay.
So most of you got the question correct. Reviewing medications, it's simple, it doesn't cost you anything, and it's something that you must do with all patients that present with any sort of problems, I feel, in clinic. The reason is because medications are often a precipitant of diarrhea. So this patient has diabetes, they could be taking metformin, which is a known cause of diarrhea. They also have hypertension, and they could be on something called olmesartan, which is an ARB, and that has been known to cause diarrhea. And when you biopsy the small intestine of these patients, they have histology that's almost similar to celiac disease. What's nice is that once you get them off of these medications, their symptoms resolve, and you've avoided extensive evaluation and saved the patient quite a bit of money.
Do you have any questions for Dr. Agarwal before we let her go? Anything on acute or chronic diarrhea? Okay, Mitali, thank you. So the next speaker will be Dr. Tran. Dr. Tran is the Director of Motility at Orlando Health. So we have asked him to talk about making dysphagia easier to swallow. So, Chewy.
First of all, thank you, Dr. B, for inviting me for the lecture today, and thank you everyone for attending. So, The disclosure, and today I talk about dysphagia, and I would like to focus on the dysphagia that we see in the clinic mostly, and I would like to exclude the dysphagia that cause a choking sensation and requiring the Heimlich maneuver, or the dysphagia that had a food bolus impaction after the Thanksgiving requiring EGD to remove the food bolus. So before going through the diagnosis and the treatment, I would like to do briefly the swallowing stages, and mostly we have two part of the swallowing phases. One is oropharyngeal phase. It's requiring the coordination between the saliva, the teeth, coordination of the muscle, including the tongue muscle and the pharyngeal muscle, which are controlled by the swallowing center in the brain and managed by the cranial nerve. And the other one is the second one, the esophageal phases, that when the food bolus go down to the esophagus and it trigger the primary peristalsis that push the food down from the proximal esophagus to the distal esophagus, and then the lower esophageal sphincter will relax and let the food going down. So it's an autonomous peristalsis reflex, so it would not be controlled by the brain or the cranial nerve. So for the GI, we focus on the esophageal phase, dysphagia, not on the oropharyngeal phase, but we need to know what we should do. And we would like to, I would like to mention some questions we need to ask ourselves. And before that, I would press the importance of asking detailed history of dysphagia with solid, liquid, the timing, the associated symptoms like odynophagia, like regurgitation, like chest pain or weight loss. But the first question is whether the patient has oropharyngeal dysphagia or esophageal dysphagia. So if the patient came with choking sensation, with coughing after eating, or when they have the ongoing neuromuscular disease, most likely they have oropharyngeal dysphagia. Whether the patient have alarming symptom or signs when they have a significant weight loss, acute dysphagia with, together with the pain when they swallow, or they have hematemesis, or they have the chest, or they have the chest pain. So you have to, we have to review any imaging that the patient have. Nowadays, when the patient go to ED, they have the CT. So that's one of the thing that we can look at, or we can look at whether the patient have previous esophagram and modified barium swallow. What we look at the dilated esophagus, we look at air fluid level in the esophagus, or any abnormal peristalsis on esophagram. We look at the barium tablet, whether it gets stuck in the lower esophageal sphincter or G junction. And we look at whether the patient have large hiatal hernia, whether that the hiatal hernia is the sliding hiatal hernia or the paraesophageal hiatal hernia. Also, we look at the previous EGD, whether the patient have ring, a Charcot ring or stricture in the past, or whether the patient have the esophagitis that have been on a treatment, especially the esophagitis nowadays with LA grade B esophagitis or more, I consider as ongoing erosive GERD. Or we look at the ring, the furrows, exudating these endoscopic manifestation of eosinophilic esophagitis, and we can look at back to see the pathology, whether they have more than 15 eosinophil infiltration, and that will help us for the treatment to the patient. And again, with endoscopy, we can look at the hiatal hernia, and we can look at how big the hiatal hernia is, and whether they are sliding hiatal hernia or paraesophageal hiatal hernia. And whether the patient has a surgical history in the esophagus, like the patient have previous hilar myotomy or POEM, or they have the fundoplication for hiatal hernia repair or anti-reflux surgery, or they have bariatric surgery, such as a sleeve gastrectomy or Roux-en-Y gastric bypass, because these things can affect the swallowing and the dysphagia in this patient. So what to order after we ask ourselves about these questions, what we order? If we see the patient have the symptoms of oropharyngeal dysphagia, we order modified barium swallow. We will ask the speech therapist consultation to help the patient to do the swallowing exercise, and we will ask the ENT to see the patient because maybe the patient need the scope from the ENT to look at the oropharyngeal area and the mechanism of swallowing. If the patient have the signs of alarm symptoms, we may need to do both, imaging CT scan, CT esophagram, or esophagram and EGD, sooner than later with a biopsy to look for the malignancy, to look for the stricture, to look for any active esophagitis. But if the patient doesn't have the alarm symptoms, usually we send the patient to the endoscopy. And if the endoscopy doesn't answer your question, we have the panel of the tests that can help us to follow the workup, including esophageal manometry, endoflip, and esophagram. Most of the facility we have esophagram first, but nowadays we have more and more centers have esophageal manometry and endoflip. And time barium study is one specific esophagram that we ask the patient to swallow about 150 to 200 cc of barium, and we take a picture at 1 minute, 2 minutes, and 5 minutes to see the column of the barium. If the column of the barium are longer than 5 centimeters after 5 minutes, very, very specific for achalasia. And that can be done if you ask the radiologist. So this is an example of the achalasia that we do with patient with the dysphagia, and we look at the imaging endoscopy. So in the middle, in the upper panel, in the middle picture, you see the bird beak, very typical for achalasia on esophagram. And the right-hand side is a sigmoid-shaped esophagus on the CT scan in the patient with long-standing achalasia. In the lower panel is endoscopy, typical for achalasia, and this we don't need to do anything because they're very, very specific achalasia. The LES is very tight and have a high resistance. We put the scope down, the abnormal contraction of the esophagus, or the bolus, food bolus there with dilation of the esophagus. And finally is the chain of the mucosa of the esophagus due to long stasis. And we see that all the time in patients with achalasia. So if we don't have anything, don't see anything on the endoscopy, or if we suggest, we think that the patient have the motility disorder, the next step will be esophageal manometry. And now today we based on Chicago classification version 4.0. What we look at the relaxation of the lower sphincter when the patient swallow, and there's an IRP parameter. We look at the peristalsis, and here the peristalsis when the patient swallow, we call the primary peristalsis. And we look at when the peristalsis start as a DL, or distal latency. And these three parameters will help us to diagnose the esophageal dysmotility or this esophageal disorder. So here the indication for esophageal manometry, one, dysphagia or regurgitation that we don't have the answer with the EGD, or when we suspect the patient have esophageal dysmotility, especially achalasia, or three, when the patient have refractory GERD, when we treat the patient and they don't respond to the treatment and they have to confirm GERD. So that could be esophageal dysmotility. And some other indication when we do before we check for 24-hour BS with impedance, because that we will know where the lower esophageal sphincter is. We do pre-fundoplication assessment before the surgeon start doing the fundoplication, or we check for the patient who had dysphagia after the fundoplication or even after the POEM treatment. So the Chicago classification 4.0 nowadays help a lot for us because it's improved from the Chicago 3.0, because there are two different positions and some additional challenge tests. So the patient will be performing 10 swallow in the supine position. And if we see the abnormal relaxation of the lower esophageal sphincter when the IRP is higher than 15 millimeter mercury, and if the patient has abnormal peristalsis, we can diagnose the patient with achalasia, either type 1, type 2, or type 3, depending on whether they have the peristalsis or not. They have the panesophageal pressurization or they have the premature contraction. If they don't have the abnormal peristalsis, they have the high IRP in supine position. We sit the patient up and we check for the IRP in the upright position. And is it still high? We call it manometric EGGO or esophageal gastric junction outflow obstruction. And that's just the diagnosis from the test. We need to know that the patient has dysphagia, and we need to confirm that with either the endoflip or time barium swallow. If we confirm that, we call that the patient have clinical relevant EGGO according to the Chicago classification version 4.0. If the patient doesn't have the abnormal LAS relaxation abnormality or IRP lower than 15, again, we set the patient up to see whether there's any change, and we do the rapid drink challenge test. If the IRP become up high, we go back to the disorder of EGG outflow on the left-hand side there and do the workup, the same thing. If the IRP come back normal, less than 15, so this may be the disorder of peristalsis, and we can diagnose the patient with a different diagnosis of peristalsis, such as absent contractility when there's no contraction, or distal esophageal spasm. In the past, we call it nutcracker esophagus, when there are more than 20% of premature contraction, or hypercontractile esophagus. In the past, we call it the jackhammer esophagus when they have more than 20% of hypercontractile peristalsis, or everything came back normal. So that, in the other hand, when we don't have any evidence of EGGO, when we sit the patient up and end of life came back normal, that will be go back to the right-hand side is the disorder of peristalsis. So you can see that here on the left-hand side, there's important end of life. The end of life play a very important role in diagnosis of the EGG outflow disorder on the left-hand side. And so what's the end of life? What we do is we use end of life with the balloon sitting across the lower esophageal sphincter. And end of life will be used to evaluate two things. One is the EGG opening. You can see the lower panel, and the other one in the upper panel is the contractile response. The difference between end of lip and manometry is that end of lip can only be done when the patient sedated with endoscopy, and it look at not the primary peristalsis, but look at the secondary peristalsis. End of lip, very, very good, and looking at the EGG distensibility and the EGG diameter, so it can help us to confirm the diagnosis of the EGG outflow disorder. On the other hand, manometry can be done with or without sedation. And with sedation, it can be done at the same time with an endoflip. It look at the primary peristalsis, and it can help us, like the Chicago classification version 4.0. We can look at either the disorder of outflow or disorder of peristalsis. So these two tests combined will help us to have more confirmed diagnosis, especially the diagnosis of EGG outflow disorder. So we can see the blue arrows is several years back when we had the Chicago classification version 3.0, but nowadays with the Chicago 4.0, with sitting up upright position, do rapid drink challenge test, and now we have endoflip. We will be really confident to diagnose the patient with achalasia, and we will be really confident to diagnose the patient with clinically relevant EGGO, because when we diagnose them, the treatment will be intervention, and we don't want to over-treat the patient. So go back to the dysphagia workup. So if the patient come in with the dysphagia, then when they have the alarm sign, we have to do the test right away with imaging and endoscopy. If not, we can do either esophagogram and then EGD with biopsy. And if no abnormality found, if the patient has symptom of GERD, we will treat the patient with GERD. If the patient already failed the treatment, or the patient that doesn't have the symptom of GERD, we send the patient for esophageal manometry, either the dry manometry or EGD. So that's the second EGD. And if the patient has the manometry show that EGJ outflow disorder, we need to do another endoflip, so need the third EGD. So we can do one thing better when we do the index EGD. We can do endoflip at the same time, and we can place the manometry at the same time. So that will help us to diagnose both disorder with peristalsis, the disorder of EGJ outflow. So what the treatment for option for dysphagia? So again, we have to look at the esophageal condition, and based on that, we treat accordingly. For example, stricture, we dilate the stricture web or a ring. We treat the EOE with 4Ds, diet drugs. Nowadays, we put on the Dupixent, we see FDA approved, and dilation depending on the state of the EOE. For erosive esophagitis, now we have more than not only PPI, we have the potassium competitive acid blockers. Or malignancy is required the multidisciplinary approach. And all the patient need to have diet modification, here the impact that how the patient to swallow better. So for the treatment of EGJ outflow disorder, the first one is achalasia, type 1, type 2, and type 3, and the other one EGJ-00. So the standard of the treatment would be hilar myotomy, POEM, or pneumatic dilation. But nowadays, with the type 3 achalasia, the standard option will be shifted to Taylor POEM, because the POEM can have the myotomy or cut the muscle longer because of the spastic characteristic of type 3 achalasia. If the patient have a contraindication for surgery, or we have to wait for the POEM, the patient can have optional Botox injection. And if the patient fail with the treatment, or when they come in with end stage the achalasia, the last resort would be enteral feeding or esophagectomy, which carry very, very high morbidity and mortality, up to 30%. So the treatment of achalasia, I just want to review with you. So the first one is the pneumatic dilation. It's very highly effective, but it requires several serial dilation with a very high volume under fluoroscopy. And it has a risk of perforation up to 4 to 5%, depending on the facility. So the hilar myotomy has been there for a long time, and now laparoscopic hilar myotomy, very effective, from 80 to 90%. The good thing of that is because usually the surgeon does it with fundoplication, so the risk of acid reflux will be less, and it has been there, held a long-term study already. The caveat is that the hilar myotomy cannot cut the muscle that long in type 3, so we can cause a residual achalasia and causing the failed treatment for the achalasia. So how about the POEM, oral endoscopic myotomy? Very high effectively, and the 83% resolving in the lower ECAR score in 5 years. It's better for the type 3 achalasia because it can be cut up to 15 centimeters, and it is considered a sun-based treatment when we fail hilar myotomy. One important thing is that it carries the risk of GERD, acid reflux, up to 40 to 50% of the time. So we keep in mind that we talk to the patient before we send the patient the POEM and give them the option, especially when the people are obese and they have the tendency to acid reflux and erosive esophagitis. We may need to do the myectomy than the POEM. So how about the Botox injection? The Botox injection have a very modest treatment efficacy, about 40% in 12 months. And it can increase the submucosal fibrosis, and advanced endoscopy doesn't like it when they cut the muscle. But the studies show that if we have a couple Botox injections before the hilar myectomy or POEM, it would not alter the outcome. So one other thing on EGG outflow disorder that the treatment regarding the treatment EGG-OO, very common when we do the manometry. So the EGG-OO defined as the impaired relaxation of lower esophageal sphincter confirmed by end of lip or time barium swallow. So the first things we have to look at mechanical obstruction. So we look at the history of fundoplication or bariatric surgery, especially sleeve gastrectomy can increase the pressure down there. We look at the paraesophageal hernia because that can compressing in the LES and can cause EGG-OO. Or esophageal stricture, and here could be the missing of the Jackie ring that we could not see during the endoscopy. So we may do endoscopy again, we may do empiric dilation. Or missing EOE with causing the stricture of the distal esophagus or the LES. Or infiltrative lesion, especially in patients who has ongoing cancer. So the EUS or CT could be helpful. However, the studies show that systemic check the CT or EUS in patients with EGG-OO, there's no change in the outcome if we do that. So if we don't see any mechanical obstruction, we look at whether the patient has opioid-induced esophageal dysfunction. Opioid-induced esophageal dysfunction can cause a picture of EGG-OO, achalasia, hypercontractile esophagus, or distal esophageal spasm. And when we do the treatment of that, the POEM, the response rate is good, 70% to 80%. However, because the patient is ongoing use the opioid, there's higher risk of having the GERD. Because the delayed gastric emptying, because the chain of peristalsis. So I have a couple of patients like that we don't know how to fix it. And if the patient doesn't have opioid-induced esophageal dysfunction, we have EGG-OO, the first line of treatment may be the POEM or the pneumatic dilation, and up to 93% rate. And if not, we have to ask to look at the fundoplication, look at bariatric surgery, and revise it. So if the patient doesn't have achalasia or the outflow obstruction, we have to look at the different disease that can carry the manifestation of absent peristalsis or EGG outflow. For example, GERD patient can show in the hypercontractile esophagus ineffective esophageal motility disorder or opioid-induced esophageal dysfunction. We can see the picture of the other obstruction there. So I go back to the treatment of disorder peristalsis here. So it includes the distal esophageal spasm, hypercontractile esophagus, ineffective esophageal motility, or absent contractility. So the first thing for us, because the GERD can carry these manifestations, we look for GERD, and if we see the patient have reflux symptom, we have to treat or confirm the GERD and optimize the treatment with the dose and with the timing the patient takes. And sometimes we need to do empiric dilation if the patient still have dysphagia. If the patient prominent symptom is dysphagia, we can do end-of-labor TBE. If we have abnormal end-of-labor TBE, we can send the patient for the POEM of pneumatic dilation. If the prominent symptom is non-cardiac chest pain and we have the spastic disorder such as distal esophageal spasm or hypercontractile esophagus. The treatment is conservative treatment with medications like smooth muscle relaxers, neuromodulator, trial Botox, or sometimes we have to look again in 6 months or a year with manometry and endoflip to look for any atypical achalasia, for example. If the patient came in with hypomortality, the treatment would be neuromodulator and behavioral treatment. So here's a very busy table regarding the medication that we use. For example, the smooth muscle relaxants, TCA, SNRI, SSRIs. You can see that they are studied in a very small randomized control study in these conditions. However, the use of them are really limited because the very high side effect. And when we use the smooth muscle relaxant, we use peppermint oil. I don't think it's worked for me, but the case series says it works. Calcium channel blockers or phosphodiesterase 5 inhibitors. The last condition I want to mention is absent contractility. When we do manometry, we don't see any peristalsis and the IRP very low. However, it can mimic the achalasia type 1 because the manometry cannot identify the real IRP. So we need to do endoflip to rule out achalasia type 1. And this absent contractility usually happens in people with scleroderma or connective tissue disorder. And the treatment would be GERD, controlling GERD with a high dose PPI. We look for candida esophagitis, nutritional support, and very, very limited the use of prokinetic. I use Resmetirom sometimes, but it's on a case-by-case basis. And only one study, retrospective study, showing that partial notification may help, but it's just a retrospective. We don't have other study regarding that. So take home point, we need to know how to differentiate between oropharyngeal dysphagia and esophageal dysphagia. We look for any other structural or inflammatory chain of the esophagus by measuring an EGD and treat accordingly. So esophageal manometry and endoflip can be used at the same time and combined to diagnose the esophageal dysmotility, including two groups, outflow disorder and peristalsis abnormality. And would like to mention that a lot of the time we see the non-achalasia spastic dysmotility, such as hypercontractile esophagus, in patients with acid reflux. So be aware that we need to treat acid reflux very aggressively. And POEM, nowadays POEM is considered as a treatment of choice for achalasia type 3 because of the characteristic of that treatment. And other than control GERD, medication play a very modest role in the treatment of the non-achalasia esophageal dysphagia, because they carry a lot of side effects, but this depends on us with the trial and errors. This one question for the end of my talk. So this 62 years old woman with no significant past medical history, 6-month history of progressive dysphagia to both solid and liquids. She also reports halitosis and regurgitation of undigested food material. She has had aversion to food and report 5-pound weight loss over the last 3 months. She also reports chest pain at time when trying to swallow. So this is called the ECA score. So she had a high ECA score. An upper endoscopy is then performed showing a dilated esophageal lumen along with retained saliva and some resistance to the passage of endoscope through the lower esophageal sphincter. Subsequent esophageal manometry show the following here. So you see that the patient has, this picture got cut because of the mark, but this patient have high IRP, very high DCI, hypercontractile, and short DL, distal latency. So this is a spastic contraction. So which of the following is preferred treatment option for a durable response? Number 1, Taylor POEM, 2, Botox injection, 3, Howler myotomy, 4, pneumatic dilation, 5 star consumption of blockers.
Okay, let's go to the answers.
Yeah, so most of us answer the Taylor poem, which is the right answer. The patient have the symptom of chronic dysphagia and have a high ECA score, including dysphagia, regurgitation, chest pain, and weight loss. So the conservative treatment would not be the option here. And the patient on the AGD showing the dilated esophagus with very high resistance of the LAS, and the manometry show achalasia type 3. So this is the treatment of this is the recommend treatment of that is Taylor poem. But yeah, then she's young, so she can be going through the poem, not the Botox injection. Thank you for your attention.
Before we let Dr. Tran go, do we have any questions for him? Slides were very, very good.
Thank you.
You covered a lot. Thank you so much. Yeah. The next speaker is Dr. Sumaira Kachru. Sumaira runs the campus for us at Dr. Phillips Hospital. She's an excellent general gastroenterologist, and she's going to talk to us about positive C. diff test. What to do next?
Thank you very much for coming today and spending your afternoon with us. And thank you, Dr. V, for this opportunity to present here. My talk today would be positive Clostridium difficile test, what to do next. So basically, we get this in here all the time. We kind of have to play a detective here and see, okay, what are we going to do next? So I'll start off with a few questions. These are going to be you guys will scan the QR code, and then we're going to have a poll. These are pre-test, pre-talk, and post-talk questions. So here we have the first case that we have is a 75-year-old male who's transferred from a nursing home with altered mental status, weakness, and dehydration. He was recently discharged from the hospital after treatment of his pneumonia. He reportedly had loose stools with use of antibiotics, which worsened with development of abdominal pain. In the ER, infectious workup showed a positive C. diff EIA toxin test. CT scan shows pancreatitis without any bowel dilation. Pertinent labs include leukocytosis, white count of 20,000, hypokalemia shows he's dehydrated, white potassium is 2.5, and serum creatinine is elevated to 1.8, with baseline being 1.2. Vitals show tachycardia, his heart rate is in 90s, and blood pressure is systolic blood pressure is low in 90s. This is patient's first episode of C. diff diarrhea infection. So what would you do next? Start patient on metronidazole flagyl, 500 milligrams TID. Start patient on fidaxomicin deficit, 200 milligrams BID. Start patient on IV vancomycin, 125 milligrams QID and IV flagyl, or start patient on PO vancomycin, 500 milligrams and IV metronidazole, 500 milligrams TID. Please scan the QR code.
Okay, let's go to the polling.
Last option. We'll come back to it at the end of the talk. More questions? Second question here is a 65-year-old female who was admitted to the hospital for past 4 days with DKA and also a complicated diabetic foot ulcer. Started to have loose stools and low-grade fever for the past 2 days. Constipated prior to coming to the hospital for a few days, for which she received some laxatives during her hospital stay. She has history of C. diff infection in the past 2 months ago. Her stool C. diff PCR So remember in the previous question, we had a C. diff toxin, and here I'm talking about C. diff PCR is positive. Pertinent labs show white count is normal, around 8,000, normal electrolytes, and normal serum creatinine. What would you do next? Confirm C. diff infection with a toxin EIA test. If positive, treat. Confirm C. diff infection with toxin EIA test. If negative, no symptoms, monitor and do not treat. Option number 3 is both 1 and 2, or either 1 and 2. Last one is stool PCR means C. diff is confirmed. No further testing is needed. Proceed with treatment. And the QR code. Show me the whole.
Okay.
Have option 3 here, both 1 and 2. We'll come back again to it after the talk. Last question here is same patient, 65-year-old with the same history. Now what we got was she has history of C. diff infection 2 months ago. We did the EIA testing, and that shows the C. diff PCR is positive, and we also have an EIA toxin that's positive. Pertinent labs are the same, and she has normal vitals. So what would be the treatment, considering this is her first recurrence? Remember, she had C. diff infection 2 months ago, and we have confirmed it with C. diff PCR and EIA. What would you start her on, considering this is her first recurrence? You start her on vancomycin, 125 milligrams IV, Q6 hours. Start with deficit fidaxomicin, 200 milligrams PO BID. Start with flagyl, 500 milligrams IV TID, or start with vancomycin, 500 milligrams PO Q6 hours. I would recommend that you pay attention to the IV and the PO doses, because we'll come to that. That's important for treatment of C. diff. And the QR code. So we got there. All right, so let's move on to the actual topic that I'm going to talk about, which is C. diff infection. C. diff infection is a gram-positive spore-forming bacteria that can lead to an infection of the colon called Clostridioides difficile infection. It's one of the most common causes of infectious diarrhea in healthcare settings. Believe it or not, it is actually causing about 500,000 cases of infectious C. diff diarrhea annually in the United States. C. diff infection reoccurs in 1 in 5 patients. Means if you have 5 patients who had C. diff, think that one of them is going to have recurrence. Also remember that C. diff may colonize our colon, so it can even be present in 2 to 5% of asymptomatic population without causing any symptoms. What are the typical symptoms of C. diff infection? You may have watery diarrhea, profuse watery diarrhea, fever, nausea, abdominal cramping, dehydration associated with diarrhea, and loss of appetite. What are the risk factors associated with C. diff infection? We all know that current and recent antibiotic use increases the risk of C. diff infection by about 7 to 10 times. It's mainly the reason being alteration in the microbiome. There are lots of studies going on in microbiome era, and we know that it plays a definite important role in multiple GI diseases. One of them being, if it's altered, we can have we are more predisposed to C. diff infection. You'll see lots of different types of microbiomes, microbiota, different kinds of microbes. But remember, if you can, that the good bacteria are the Bacteroidetes and the Firmicutes. If they are low in our colon, and if there is increased bad bacteria, which is Proteobacter, that is actually an alteration in the microbiome and can predispose to C. diff infection. Again, elderly patients with age more than 65, hospital admissions for patients more than 8 hours, especially if they're admitted through the emergency room. Again, patients were admitted to the ICU. Why? Because usually in ICU you have patients who are on multiple antibiotics with carbapenems, with multiple antibiotics, so they are at high risk of C. diff infection. Patients who are residing in nursing homes, they're at high risk of C. diff infection. And again, very commonly, we all know that how common PPI use is. Patients who are taking long-term chronic PPI use, or if they have had gastrointestinal surgery, or they're for some reason immune suppressed, or if they have IBD. All these are risk factors for C. diff infection. So how does C. diff look endoscopically? We are GI physicians, so we are interested to see how endoscopically C. diff appears. So the first picture that you have on the right side is just an inflamed-looking colon with some ulcers and whitish plaques. On there, does this work? I wanted to use the clicker. So the one in the middle is, you see the pseudomembrane formation. It's like a really extensive C. diff infection. And the one that shows the creamy white fluffy patches are basically just C. diff infection. They are, it can be anywhere from mild small plaques to florid severe pseudomembrane formation. Now, one important thing to know is, what are the antibiotics? We know that there are antibiotics that can increase the risk of C. diff infection, but this table will show you the antibiotics that are frequently associated with C. diff infection. So you all know that we don't get to prescribe a lot of ciprofloxacin, levo, moxifloxacin, fluoroquinolones are high on the list. So try to avoid them if possible. Number 2 is clindamycin. Clindamycin also increases the risk of C. diff, definitely much higher than other antibiotics. Penicillins, which particular penicillin? Broad-spectrum antibiotics like penicillin antibiotics like doxycycline or amoxicillin, augmentin. And then lastly is cephalosporins, the 2nd, 3rd, and 4th generation cephalosporins. But also, we do prescribe cephalosporins in the hospital for prophylaxis for surgery like Ancef or Keflex. Those are not, 1 or 2 doses doesn't increase the risk of C. diff. There are other, on the table you see occasionally associated and rarely associated. Those are something to remember, but mainly, try to avoid the first category, which are frequently associated if possible. All right, now we have a positive C. diff test. So we get a consult that there is a positive C. diff test. What do we do next? It's important. As I said, we have to kind of play a detective here and say, okay, well, you have to look into the history and do all your background work to see what needs to be done for this patient. The most important few questions that you have to ask yourself is, what was the testing modality? If you remember in the questions, I did mention the EIA toxin and the PCR. So it's important to see, okay, C. diff is positive, but which type of C. diff was positive? Was it an EIA toxin? Was it a PCR? Because I'll tell you what the significance of those tests are in the next few slides. The next question to ask is the patient symptomatic? Or is the patient not symptomatic? It's just a positive test, because that changes the management. Remember, I told you that C. diff can colonize in your colon. So if you have a positive C. diff and patient has no symptoms, then the whole management is going to be completely different. Third thing is clinical context. So you have to see, well, is this patient's first recurrence, first infection, or is it a recurrence? Because the treatment options will change. Then again, you have to also kind of understand and see, what kind of population am I dealing with? Is this an immune-compromised patient? Is it an elderly patient? What are the other comorbidities? What was the antibiotic exposure? Because you would want to stop that antibiotic if possible. And again, immune-suppressed and IBD patients, the treatment is slightly different. Then the fourth thing is severity of the infection. How severe is the infection? Because you will know that we have to classify C. diff, and severity, to know the severity of infection is important. And then what treatment, again, the question is, what treatment do we start and for how long? That will be decided based on all the above things that we talked about. And lastly, are we implementing all the preventative measures, and are they followed correctly? All right, talking of C. diff testing, very, very important for interpreting a test that we have in our EMR is that we have to understand that we have to interpret this test based on sensitivity, specificity, positive predictive value, and cost and turnaround times. Most commonly used test is the PCR test, which is a nucleic acid amplification test, NAT test. It has a high sensitivity and a high specificity. But remember, this PCR is positive. If it's positive, it doesn't tell you that it's actually the patient is having an infection, because it can still be a colonizer, and it can be clinically false positive due to lack of toxin production. So if you can take away one thing, would be look at the toxin, specifically toxin B, because that actually causes C. diff symptoms, not just a stool PCR, which is positive. Yes, it does. Stool PCR has a good sensitivity, but toxin determines if this is actually an infection happening here. Most of the places, they do a two-step assay combining an EIA, which is an enzyme immune assay test, for glutamate dehydrogenase. Glutamate dehydrogenase is actually an enzyme which is a very sensitive test. Lots of Clostridium difficile type of organisms can have glutamate dehydrogenase positive. It doesn't mean that the patient has infection, it just means that there is some kind of C. diff present, toxigenic or non-toxigenic. But when it's combined with an EIA toxin, which is actually the toxin that causes the disease, that makes the combination test very useful, because first you're getting the GDH positive population, then you're trying to see if you have an EIA toxin positive. If you have the toxin positive, then, and the patient is symptomatic, that confirms the diagnosis. An EIA assay for GDH is highly sensitive for C. diff infection, but lacks specificity, as I mentioned. A positive GDH is followed by an EIA toxin detection, and when both are positive, a diagnosis of C. diff infection is made. In case there is a discordance, means you have a positive GDH, but a negative EIA, what do you do? So, well, you have a GDH positive, but toxin EIA is negative, then you do a stool-based PCR test, which is used for arbitration. Because if you have a patient who is symptomatic, but for some reason the toxin is negative, you do a PCR, and if the patient is symptomatic, you treat them. This is again talking about the same test for C. diff. You see I have highlighted the first three, the GDH, toxin AB immunoassay, and the NAT, or the PCR test. You have number 4 and number 5, which is, these tests are all sensitive and specific, but the turnaround time is really high. This cell culture cytotoxicity neutralization assay and toxicity cultures have high sensitivity, but the turnaround time is really high. This is a good table I like, because this is from ACG. It's an algorithm that tells you how to proceed when you have a C. diff positive test. So, okay, well, the patient is suspected. The top, I wish we had the top box shows the patient with suspected C. diff infection. What do? You start with a really highly sensitive test, which is either a GDH or a NAT test or a PCR test. If GDH or NAT is negative, it's not C. diff infection. If it's positive, proceed with a more specific test, which is a toxin test. If the toxin test is positive, this is C. diff infection. If the toxin test is negative, either it's not C. diff, or it's a falsely negative toxin. We couldn't really get the toxin. It was below threshold to be measured. Those are the clinical scenarios here. And then if that's the case, then the most important thing is clinically assess the patient. If you're thinking that patient has symptoms and the suspicion is high, we do the NAT testing, consider NAT in GDH negative patients with high clinical suspicion. If there is high clinical suspicion, it trumps everything else. You start them on the empiric treatment for C. diff. The second question was, is the patient symptomatic, right? We talked about it. If the patient is not symptomatic, do not test them. C. diff PCR can remain positive up to 6 weeks after completion of treatment. So you may have a patient who comes in with C. diff infection, had it in the past, comes and for some reason gets a stool test and shows stool PCR positive and has no symptom. Doesn't mean that they have C. diff infection. It just means that they are colonized with C. diff, which can remain positive for up to 6 to 8 weeks. Asymptomatic C. diff carriers do not need treatment. If answer is yes, the patient is symptomatic and the clinical suspicion is high for recurrence, even if the toxin test is negative, as I said, if the suspicion is high and for recurrence, the patient had C. diff infection, these patients should be treated. Clinical context, why is it important? Because you have to see if this is patient's first episode or is it a recurrence. What number of recurrences this? Because that's important, because when we are going to be deciding about Beckler fecal transplant, the number of recurrences is important. Old, frail patients, more than 65 years of age, immune-compromised, and IBD patients. Sure that you are reviewing and paying attention to these things. As I said, severity of the disease is important. Why? Because the treatment is going to be based on depending where they fit into this category. The clinical definition, so if you have C. diff, you have to kind of put them in one bucket. You have to either, if based on two things, you have to look at their labs, their white count, and their serum creatinine. Only these two things, and also again, for fulminant, if the things to keep in mind is they may have ileus, they can have toxic megacolon, they may be hypotensive or in shock. So if it's simple, non-severe C. diff patients have a white count of less than 15,000, and then their serum creatinine is less than 1.5. For severe C. diff patients, white count is more than 15,000, and then serum creatinine is more than 1.5. So what is fulminant? You usually have severe C. diff plus ileus, toxic megacolon, hypotension, shock. That defines fulminant C. diff colitis. The last question on our chart, the first one was preventative measures for C. diff infection. Important to know that once you have a confirmation that we are using gloves, gowns, and mandatory hand hygiene using soap and water, the alcohol is not enough because C. diff spores can still be present, so it's very important to use soap and water. And the other thing that we get asked all the time is that we have started patients on antibiotics. Should we prophylactically put them on probiotics? There is no such rule that probiotics prophylactically, putting patients who are getting antibiotics will prevent them from getting C. diff. So that should be discouraged. The other thing is that patients who have had C. diff infection, what if we put them after the C. diff infection on probiotics? So does that prevent them from having recurrent C. diff? No, there is no data that suggests that keeping patients with C. diff after their episode will prevent them from having a recurrence. Coming to the treatment of C. diff infection. This is a good algorithm, and basically it summarizes the treatment options. Well, now we have a confirmed C. diff diagnosis, the top box. What do we do next? Next is classify these patients based on the definitions. Are we dealing with fulminant C. diff colitis? Or what would that entail to? Patient would have hypotension, shock, may have ileus, megacolon. If that's the case, then patients remember vancomycin 500 milligrams PO. You might think IV is better, but no. In C. diff patients, you have to use PO vancomycin because that's how it reaches the colon by PO, enteral use. So the dose of vancomycin here is 500 milligrams PO every 6 hours for 10 days. In addition, for fulminant, they also recommend metronidazole 500 milligrams IV TID for 10 days. If ileus is present, patients can't eat and they can't get enteral PO, then it's recommended that you can do vancomycin either by rectal enemas, and that's the mode. By rectal enemas, you can give them the vancomycin. Well, that was fulminant. Coming down to now non-severe and severe cases. Now, if the patients don't have fulminant colitis, fulminant infection, and now the thing that you have to ask yourself, is this an initial episode? Or is this a recurrence? If this is an initial episode, again, is this severe or is this non-severe? And severe would mean white count of more than 15,000 and creatinine of more than 1.5. And if this is severe, the first line of treatment is fidaxomicin. If you remember, these are up from the updated guidelines, and it's the IDSA and the SHIA guidelines combined together. They place fidaxomicin higher than vancomycin, even for the first episode, because there is data that shows fidaxomicin, if you treat them, there is less recurrence of C. diff with fidaxomicin initial dose. So for non-severe patients, C. diff, you do fidaxomicin 200 milligrams, BID for 10 days. And an alternative is vancomycin, 125 milligrams PO. So look at it, it's PO, both of the medications are PO. If this is not severe, they still recommend, IDSA and SHIA still recommends fidaxomicin as the first line. However, ACG guidelines do mention that you can still do metronidazole, but the IDSA and SHIA still recommend fidaxomicin as the first line. An alternative can be vancomycin. But one thing to remember, if you are treating someone who has non-severe C. diff and are treating with metronidazole, make sure that they are not elderly patient and don't have comorbidity. So younger patients less than 65 without comorbidities, that can be an option. But again, if you really follow the IDSA and the SHIA, it should be fidaxomicin. Coming to on the other side, we have, the initial, it's not the initial episode, it's a recurrence. Then you look at if this is a first episode or if it's a second episode. For first episode, again, it's fidaxomicin, 200 milligrams, but what's the difference? You can do a tapered course of vancomycin here as an alternative. And at that first recurrence, you also evaluate them if they would be candidates for bezilotoximab, which is a monoclonal antibody I'll talk about in the next few slides. And then if it's a second episode, you do fidaxomicin tapered dose, or you can do all vancomycin tapered dose. Also, at the second recurrence, the guidelines do recommend evaluate if they are candidates for fecal transplant. So C. diff infection treatment for initial non-severe C. diff, metronidazole is still recommended by ACG, but SHIA and IDSA, as I mentioned earlier, do not recommend. Fidaxomicin has a narrow spectrum of antimicrobial activity and has shown to be more effective to prevent recurrence. Society of Healthcare Epidemiology of America, SHIA, and the IDSA clinical practice guidelines position fidaxomicin above vancomycin for treatment of an initial C. diff infection. This is basically, these few slides are the breakdown of what we already talked about. Initial C. diff infection, we already talked about what the preferred regimen is, what an alternative is, and how to treat the severe versus non-severe. This is for you guys to review. This is, again, the same thing for the subsequent C. diff infection, which we always we get this, what do we do next for subsequent C. diff infections? For the initial severe and non-severe, we have, it's straightforward. But for the subsequent, that's when you are okay, is this patient a candidate for fecal microbiota transplantation, or should we consider bezilotoximab, which is basically an IV, kind of like a passive immunity you give patients so that it prevents them from having recurrent C. diff infection. One thing to remember is that if you are giving someone bezilotoximab, be careful with patients who have congestive heart failure. Again, this is fulminant C. diff because I think there was a question, so pay attention here. For the fulminant C. diff infection, you're going to give vancomycin orally 4 times a day, and you also either by NG tube or rectally, or you also add flagyl to it. And talking of the bezilotoximab, basically it's, as I was telling you, it's a passive immunity. Kind of think about it as a passive immunity. It's a human monoclonal antibody. What it does is it basically binds to the toxin of C. diff. So you have this on the chart here. I don't know if it is. Yeah, here. You see this is basically bezilotoximab. It is a monoclonal antibody, and, sorry. Yeah, so bezilotoximab is this antibiotic, and it binds with the toxin that C. diff is producing. So once the C. diff toxin binds with the bezilotoximab, that toxin doesn't go and bind with the actual host cell. So this bezilotoximab binds that antibody, and it prevents the toxin to go and attack the host cell. So it's kind of like a passive immunity. It helps to prevent recurrence of C. diff. Now, talking of fecal microbiota transplant, we know conventionally how we do fecal microbiota transplant is with the colonoscopy. You go and you transplant the stool inside the colon, the sick colon, and with the aim that we are going to provide biodiverse microbiota, which will help for treatment of C. diff. But there are other ways, simpler ways that FDA has approved for fecal microbiota transplantation. One is this VOWST. It's an oral capsule. You can 4 oral capsules. It has actually microspheres, microspores, microspores, and you take 4 capsules a day for 3 days after patients have completed C. diff treatment, and this has shown to prevent recurrence of C. diff. And then you have, on the right-hand side here, you have Rebiota, which is basically a fecal transplant, but it's not done via colonoscopy. It is done in the clinical setting. You can do that actually in the form of an enema. It's you use the specific bag and do an enema and basically use that, and it's supposed with the patient positioning, it's put in the rectum, and that helps also with the recurrence of C. diff. So Rebiota, Vowst, and our conventional fecal microbiota transplantation. Now, things to remember when we have, switching gears here, that you have a C. diff infection. And remember, I was telling you, you have to know the clinical context and what population you're dealing with. If you have a patient with IBD and has C. diff infection, remember these IBD patients are at a very high risk of C. diff infection. Overall lifetime risk of an IBD patient to have C. diff is about 10%. And not only infection, they're also at a higher risk of recurrent C. diff. Compared to the general population, they're at 4.5 to 5 times higher risk of having recurrent C. diff. It's important to know that, because the treatment here is going to be different. Conventionally, if you remember the previous guidelines, they always said metronidazole. Now we have vancomycin that we give for severe for C. diff patients up front for 10 days. But for IBD patients, they recommend increasing the dose to 14 days. So that is a difference here. Generally, a regular person without any immune suppression or IBD, you give vancomycin for 10 days, but for IBD, you actually increase it to 14 days. If there is, the other question is, like in the past, we used to debate, do we need to take these IBD patients off of their immune suppressive medications? But the data and the studies have shown, no, you need to continue their immune suppressive medications while they're getting the C. diff treatment. And if there is no improvement and they are on immune therapy, then you need to do a colonoscopic exam, and maybe that's the time to increase the immunotherapy or change the immunotherapy. But the important thing to take home is, do not stop their immune suppressive medications. And for refractory and recurrent C. diff infection and IBD, consider early consideration of FMT. In general population, we start considering FMT after second recurrence, but with IBD patients, consider starting it early on, maybe even after their first recurrence. Few miscellaneous points to remember is that we have these sick patients who are getting PO vancomycin, fulminant colitis patients who are getting PO vancomycin every 6 hours. Remember, because the colon is so sick, you can have absorption of this vancomycin into the systemic circulation, and they can have kidney function deterioration. So if you are having a patient who has fulminant colitis, getting round-the-clock vancomycin, it's important to monitor vancomycin levels in these patients. That's for fulminant colitis patients who have a sick colon. Again, metronidazole should be generally avoided in adult patients, frail individuals, and patients with inflammatory bowel disease. There's no role of metronidazole in IBD at all. And then bezlotoxumab is contraindicated in patients with history of congestive heart failure. And the last one is vancomycin is the first line of treatment for IBD patients or a patient who is pregnant or breastfeeding. You don't play with other medications with pregnant patients or breastfeeding patients. Vancomycin is a safe medication. All right, coming back to the clinical cases, hopefully you will get all of these right. So again, we have this patient now. I'm going to summarize this. We have this 75-year-old patient, nursing home patient comes in. He has a positive C. diff EIA toxin test, a very specific test, and his white count is 20,000. He has pancreatitis, he has hypotension, and this is patient's first episode of C. diff infection. So this kind of qualifies him to be a fulminant C. diff infection. So what would you do next? The options are in front of you. Please scan the QR code and we can look at them.
Okay, let's...
Jason, please show me the poll.
Yep.
So, all right. I don't think I did a good job in teaching that. 5%. Yes, you guys, 45% got it right, because this is fulminant colitis, right? So you have to remember it's PO vancomycin. There is a distractor, and IV vancomycin is never an option, going to be an option. It's PO vancomycin, 500 milligrams, 4 times a day, and then you also add IV metronidazole, 500 milligrams TID. So this was fulminant colitis. Yeah, that's the option. Now, the second question was the female who had C. diff infection in the past, and now she comes and has some diarrhea, and stool C. diff PCR is positive. It's a sensitive test, but remember, it's not a specific test, right? So her labs are normal, she has normal electrolytes, and she has normal serum creatinine. What would you do next? Confirm C. diff infection with the toxin EIA test. If positive, treat. Confirm C. diff infection with the toxin EIA. If negative and no symptoms, monitor and do not treat. Third is both 1 and 2. And the last is stool PCR means C. diff is confirmed. No further testing is needed. Proceed with treatment.
Okay.
Most of you got it right. 78% of you right means both. Remember, PCR was not a specific test, right? It's not a confirmation for PCR. PCR is not a confirmation for C. diff. You have to test with a more specific test, right? And if you confirm with the toxin EIA test and it's positive, treat. But if it's negative and there are no symptoms, don't treat. So both 1 and 2 are correct. Last question is the same patient, 65-year-old patient who was admitted in the hospital for past 4 days with DKA and also complicated diabetic foot ulcer. She has C. diff infection 2 months ago. Her stool is positive. Now her stool is positive for C. diff PCR and an EIA toxin. This is real C. diff here. So patient labs show normal white count, normal electrolytes, and normal creatinine. What treatment would you start her on, considering this is her first recurrence? You start her on vancomycin 125 milligrams IV, you started on fidaxomicin, PO BID, you started on metronidazole, or you started on vancomycin 500 milligrams PO Q6 hours.
For the answers.
Excellent. You guys, 88% got it correct. And yes, this is first recurrence. And remember, fidaxomicin, to begin with, it should be the first, it's the first line of treatment, even for the first episode and also for the first recurrence. You don't do vancomycin IV, you don't do flagyl, you don't do vancomycin PO. So fidaxomicin is a preferred agent for the first recurrence. Vancomycin IV is never given. Metronidazole, IV TID in conjunction with PO is only for fulminant colitis, and vancomycin 500 PO Q6 hours is for fulminant colitis. Well, thank you very much for your attention. These are a few pictures from my hometown, Kashmir. Hopefully, you guys can visit there sometime. Yeah, thanks again.
Before we go to the next speaker, does anybody have any questions for Dr. Kachru? She's like she reminds me of my Catholic nuns at high school, so I'm usually intimidated and I don't ask her any questions. But anyway, thank you, Sumaira. The last speaker is Dr. Shahjan Peter from UAB. He's a very, very, very close friend and my former colleague at UAB. We go for the last 20, 23 years. So I asked him to talk something on NG, NJ, PIG, and PIG-J. These options are very difficult to choose from. So he's going to give us a practical outline on when to go with what. Welcome.
Hey, good afternoon. Thank you, Shyam. It's really a privilege, honor to be here. Always, you amaze me always, and every time I come, I'm just amazed. Your hard work, your dedication is what pays off. This is a world-class institution you've built. Orlando protocols are known all over the world, and not but least, but your dedication to education and teaching others is just what makes you special. Thank you for this, giving me this topic to talk on. And I think this is a common area that we always deal with on a day-to-day basis, you know, enteral nutrition, how do you manage it? A lot of time as GI, we're putting tubes, right? We put in endoscopic tubes, and that's how we're called in. As you know, nutrition is, the GI tract is a long tube. It's a long tube, and one of the most important things is nutrition, besides other things. So nutrition is what keeps it going, without a doubt. My aims are here to understand the indications for enteral feeding, identify various options for enteral feeding, as well as advantage or disadvantages of each type, discuss the complications, and how to, because this is something we see as a common practice. These are some of the definitions of enteral access. It could be nasogastric, nasojejunal, orogastric, orojejunal, and then you switch to gastrostomy, which is a percutaneous endoscopy, which is PEG, or a PEG with a jejunal extension, a surgical gastrostomy, a radiological gastrostomy. Then there's a jejunostomy, which is a percutaneous endoscopy jejunostomy, or what we call a direct PJ. This could be also surgically done, which is surgical jejunostomy. But if you look at this image, it shows it's kind of split. One is based on the time, short term versus long term. The other one is where you place it, right? So a lot of absorption takes place in the intestine, so you want to place it either pre-pyloric or post-pyloric. And so each of these tubes have a role. Either you place it pre or post, is it short term and long term? And these are the tubes you can see. The gastrostomy tubes is in the stomach, pre-pyloric. The jejunostomy tubes are post-pyloric. If it's short term, you're pretty much looking at those tubes which are mostly nasal placed or oral placed. If you're putting a surgical and a gastrostomy, it's usually a permanent or a little bit more longer phase. The indications are vary, and this is what we come to see in a daily practice. And dysphagia, Parkinson's disease, malignant tumors, benign strictures, critical patients in ICUs with acute pancreatitis, for example, anorexia nervosa. And then if you have a nasal jejunal enteral axis, it's like symptomatic gastroparesis, gastric outlet obstruction, severe reflux, so you want to avoid aspiration. Long term is that, again, these are ones which we talked about, which will come as we move along. What are the conditions for deciding on the route of enteral? So if it's a short term, around 4 weeks to 6 weeks is what we are talking about. If you think of a patient needs feeding for just less than 4 weeks, then you're talking about a nasal, oral, or a transpyloric tubes, which are basically nasal or oral placed. If you're talking of more than 4 to 6 weeks, and you identify, then you start thinking of putting a PEG or a PEG-J. This is an interesting slide, and it shows how frequency of tubes have been placed over different providers over the last few years. And interestingly, you see the black one, the GI doctors are placing less of tubes. But look at the one on the low, the violet, the purple color. Do you see that one? APPs are placing more tubes nowadays. So therefore, it's a very important role where enteral tubes are being, a role changed over the last few years. Short-term tubes, we put it many times, but important things to note is that you don't want to push it into the lungs. It could be life-threatening, and there's a potential for gastric esophageal perforation. You need to verify with an X-ray. Skin breakdown, especially ulceration of the nares, potential sinus infections can happen. And sometimes you consider putting a bridle, and this is sometimes we ask our surgical colleagues to put a bridle to keep it there so it doesn't pull it out by inadvertently. Long-term access tubes, which is the PEG or PEG-J, you have to use an endoscope to give you a guide to put a creation of a small opening. And it could be the different techniques, pull, which is the most commonest that we use, could be push or introducer type. I won't go. This is a slide from the Orlando system, and it's a very nice slide which shows you exactly, the graph shows you how these tubes are placed. And there's a bolster which keeps it in position. Now, these tubes can be put by IR or endoscopically placed or surgically placed. You can call all of your colleagues and this is a good slide which shows you that which of these techniques are better. And it shows actually the odds of perforation or hemorrhage or infection is more with other forms of placement, IR or surgical compared to endoscopy. So endoscopy clearly should be your first choice to put an endoscopy placed tube. That should be the preferred first choice. If it doesn't work, then only you start thinking of putting other choices. And we'll come to those situations. So what are the contraindications for PEG placement? One is limited life expectancy, dementia. You think dementia patients, actually they have a bad comorbidity with placing PEGs. Ethical issues and technical issues, you can't place it with an endoscope. Other things like coagulopathy, gastric varices, ascites, altered anatomy, morbid obesity, or metastasis in the abdomen can be contraindications. But also remember ventral hernia, look for that. Sometimes people put a mesh there. Remember the skin is very thin there, so it's very difficult to put a PEG and it can cause a problem. It can pull out also. So the pre-PEG assessments or requirements are review active medications, Plan for prophylactic antibiotics. So antibiotics are important to prevent infections. Usually you want to give it 30 minutes before the procedure. Cefazolin is what we commonly use. Stop antithrombotic agents. I won't go too detailed into that, but this is a high-risk procedure, so you want to make sure that patients are adequately stopped on whatever medications they are on. And look for other previous surgeries, baseline nutrition status, obtain an informed consent. Technical tips, I won't go too much into this, but I want to show you this slide here. This is one of our patients recently who came, and they referred her for a peg placement, and we looked at a CT scan, and if you see the arrow there, this is basically the liver actually is kind of overshadowing the stomach. So when you see this patient, you know this is very difficult to place a plug tube placement. You see there's no window. So the important thing is getting a window. You need a nice window between the abdomen and the stomach. This is by shining a light through here, and the light transilluminates, and you can see that point where you can see the exact position to put a peg tube. There's a safety technique. You put a needle and place the bumper at least 0.5 to 1 centimeter from skin surface, not too tight. Post-op considerations, pain management, initiation of feeds, monitoring of peristomal skin and skin care is important. Patients keep asking, when do I take a bath, for example? And you should say maybe 24 hours you can go, but you can clean that area. Caregiver education is very important. It's not just the patient themselves, it's the caregiver that needs to understand. A lot of patients, we get referrals from inpatients, so they are admitted already. And most of the patients that I put PEG tubes or direct jejunal tubes, I admit them for a 24-hour period observation and then discharge them the next day. The reason is once you want to look at the site the next day, make sure it's rotating well, it is in correct position, and also you want to make sure the patient is educated properly for that. What are the complications? This is what we get called to. Complication, aspiration can happen during the procedure. It could bleed. Peritonitis. Sometimes you go and put the needle or peg, it can pull out and go into the peritoneum. Fortunately, these complications, which are major, are very rare. Inadvertent removal can happen per feeding tube. You can pull it out. It could leak, it could get clogged. This is what you're going to get called many times. I got a clogged tube, granulation tissue around the site, infections, fistula formations, buried bumper syndrome, and rare lineoplastic seeding. So a clogged tube, this is what we're getting called for many times. Well, an important thing is to teach them properly how to clean the tube or how to flush the tube. So flush it every 4 to 6 hours during continuous feed, every 8 hours if it's not being used. Medications are a big culprit. They can get clogged in, so try to use liquid formulations, soluble, dispersible medications, use warm water, push and pull motion syringe. Try carbonated beverage like Coke, for example, can help. And sometimes you may have to remove it. Sometimes, recently one of our advanced nurses, she was able to put a guide wire and declog it, but be careful with that also. You don't want to use a very stiff wire, but just gently you can push it and declog the whole tube. Tube dislodgement. Now, patient can pull a tube out and he comes to, and so within the 4 weeks before the tract matures, this is very important to know because it takes 4 weeks to mature a tract. And you want to repeat the procedure urgently if it's done within the first 24, 48 hours. NG tube or decompression, start antibiotics because it could have gone into the peritonitis. And if you see peritoneal signs, you need a surgical consult because sometimes they have to be taken out surgically. But this is something you need to warn the patient and the caregiver that 4 weeks is an important period for them to keep the tube. If it's after 4 weeks, when the tract matures, you can replace it by a caregiver at a local ER, preferred within 1 hour because sometimes it just heals out. It can close off even in 1 hour. So sometimes even just a red rubber tube is enough. You can put it there, go to a next doctor, and he can replace the tube. So remember, these can close really fast. When do you start PEG tube feedings? Medications, actually, you can start them immediately. A lot of patients admitted in hospital, they need them. You can start it immediately. Tube feedings, typically after 4 hours after placement, start slowly, 20 cc per hour, advance every 6 to 8 hours. Bolus intermittent feeds, or is it could be just gravity or using a syringe technique. Infections, and this is something, again, we get called for. Incidences goes up to 30%. There are risk factors of immunosuppressed, steroids, obese patients. They can get simple redness to more beware of abscesses, intra-abdominal collections. You may need to do a CT imaging. And fungal infection is something that you need to be aware of. Sometimes candida can happen. So you might be treating antibiotic and not respond, but it might be just a candida infection. So look out for that, and you may have to treat that appropriately. And IND or surgical debridement rarely needs to happen sometimes. So infections, be careful. And the last thing is sometimes you may have to take the tube out if it doesn't settle, to just remove it, let it heal by itself, and you bring it back and you can put another tube once everything settles down. Peristomal leakage this is a very common problem. I mean, I know many times you see this. It just leaks, they're calling you, the tube's leaked. And many times it happens because extensive torsion, tension, when you're laterally pulling it, it prevents wound healing. Infection, or sometimes what's called a buried bumper. The bumper actually sticks into the abdomen. That makes it leak more. So persistent thing can cause skin breakdown. It's a nightmare. Patients are worried. They come repeatedly to see you. Management with low profile tubes. So using shorter tubes, which are much more low profile. Skin like any stomach care kind of thing, treatment. Acid suppression. The acid is one prevents healing. So put them on a PPI if they need acid suppression. Barrier creams like Desitin or zinc oxide. Treat the underlying infection. Again, fungal infection, keep it in the back of your mind. Avoid or tighten the bumper. Now, this is something I want to underline very carefully. Don't tighten it. You think it's leaking? I want to tighten it? No, don't tighten it, because tightening makes it even worse. And the next thing is don't replace it with a larger diameter tube. Your first instinct is to go put a bigger diameter tube to just stop the leakage. But actually that worsens things because it increases the space and also prevents healing. You want it to heal on the tube by itself and then close off by itself. So those are two important things that I would underline. Buried bumper syndrome is something when the PEG tube migrates into the abdominal wall, the predisposing risk factors of weight gain or extensive torsion. This is one of our patients also with a CT scan showing it sitting right in the abdomen, the bumper. It could be incomplete or complete. With complete, then you have to sometimes surgically remove it. I have sometimes gently try to pull it out, and with gentle traction, you can pull it out externally, but it depends how much of fibrosis has happened around the tube. There are other techniques. You can use an endoscopy to remove it. If you just see the glimpse of it from inside, you can use a needle knife and cut it, or use a grasper and pull it out. So these are some techniques that you can use. But remember, this is a problem. And so the tube is not flushing properly. Keep that in the back of your mind. Is this a buried bumper or it's severe pain? He comes with complaints of pain around the abdominal wall. Then it's not rotating well. Doesn't rotate well. Think of a buried bumper. Predisposed. This is another very rare complicating factor, fistula, which happens usually when you don't place it properly. And so you see this patient, it's like predisposing a larger diameter of the tube, longer indwelling time, poor wound healing. The management is you can denude the stomal tract to make it heal by itself. It persistently can cause a fistula, and you can ablate it with argon plasma coagulation, and a mechanical closure it can be done, and with a suturing device, or what is this here in this video? There's something called a bear claw, and if you see this is a bear claw device, which is an over-the-scope clip, and you can attach it to a scope and deploy it and actually close the fistulous tract. That's how it's deployed, the bear claw. So this helps in many times with fistula closures. Bowel perforation, a very rare complication. Remember, this can happen also, but can go to the colon because the transverse colon just sits in front of the stomach. That's why you want to see the light carefully. You want to see the indentation carefully. And if you see the needle, this is a safety technique. You put a needle in. As you're putting the needle in, you aspirate. Aspirating, you feel the air. If you've gone through another lumen, you'll see air coming out. That tells you you're in some other lumen. So safety technique is very important. And actually, I've had one complication. This is one of our patients with a patient who complained she had constipation actually after tube. She couldn't pass stools. And then she came to the ED. They did a CT, a reported fine. It looks normal. And she came back later, sent a picture on a saying, I got stools coming out of my PEG site. And we reviewed the CT scan. It was clearly in the colon. This had to go get it surgically removed. So beware that this can also happen. Now, these are a few of the conditions that we do. Some of our patients, this is an ALS series that we did with motor neuron disease. Some of these patients are really debilitated, but we put in PEG tubes before they have respiratory compromise, and they have good outcomes with quality of life. Now, replacement of tubes, you can do that at scheduled intervals. Remember, the stomach tract should be mature. You can use it as solid or balloon types. Most of the time, we use a balloon to replace it. Post-pyloric enteral access, that's when you have impaired gastric emptying, inability to place a PEG, pancreatitis, feeding intolerance. This is actually one of our patients who had hyperemesis gravidarum, and she couldn't tolerate any feeds. She needed to go on TPN, so we put a jejunal tube, and this came on the cover of their OBGYN journal. But she did fine till pregnancy. We removed it after pregnancy. She did okay. Lung transplant patients, another frequent cause we get called for. These patients have gastroparesis, so they don't have, because of vagal injury after transplant, the stomach doesn't pump. They have a lot of food. If you see the first image, a lot of food in the stomach. We put a gastric tube and a jejunal extension, and that helps these patients gain weight and nutrition. And more important, they want to prevent aspiration. In a fresh lung transplant, you don't want aspiration. To avoid that, you put in a PEG-J. The direct jejunostomies can be put in altered anatomy because they don't have a normal stomach, for example, gastric bypass patients. In this series, we did a patients with a lot of Roux-en-Y gastric bypasses, put them direct jejunostomy tubes, and they were able to weight gain and maintain their albumin levels. This is one of our series where we compared direct jejunostomy or PEG compared to surgical placed tubes. And we found that the success rate, infection rate, bleeding rate, and perforation rate was almost similar, with actually the endoscopy placed tubes doing slightly better than surgical placed tubes at 90 days. So surgically, nowadays, in fact, the surgeons call us to put in endoscopy tubes because they feel it's a much less riskier procedure and we're able to take care of it. When do you decide between a direct J and a PEG J? The direct J has some advantages: decreased migration, less kinking, more distal jejunal access, larger diameter tubes, less clogging. They're technically more complex, and PEG tubes, you can put it, the placement rates are much higher. These are some technical tips I won't go through for placing PEG-J tubes. And for direct J also, we use CO2 inflation, and selection of patients is important. Obese patients, is difficult putting these direct J tubes. And the important thing, when you put a direct J, you can't pull it out externally bedside because the wall between the jejunum and the abdomen is very thin. So just like a stomach, you can pull it out easily. In a jejunum, tell them don't pull it out externally. It has to be endoscopically removed for this reason. Refeeding syndrome, the last thing I want to point out. Refeeding syndrome is something to be aware of. And some patients are really low BMI, anorexic, you need these nutrition. But feeding them can cause also a problem. They can have electrolyte abnormalities, potassium, phosphate, magnesium goes down, they have organ failures. So remember to feed them very slowly and gently. So you start treating just kind of slow increasing the feeds over a couple of days, monitoring the electrolytes till they're able to tolerate feeds. So remember, refeeding syndrome is a problem, especially in patients with low BMI. This is the algorithm. So short-term, long-term, pre-pyloric, post-pyloric, where do I need to give the nutrition? Based on this, you decide which is the tube that you're going to put. Is it nasal, or is it gastrostomy, or a jejunostomy placement. Take-home points: enteral nutrition is better than parenteral. Early initiation is beneficial. It's important to select your patients to guide you in access route and delivery. Complications are few, but need to be minded and recognized and managed appropriately. This is not just endoscopies putting a tube and walking out. This is a multidisciplinary care. Everybody, nurses, staff, the caregiver, and most importantly, a nutritionist and dietitian has to be part of this team for good enteral nutrition care. Thank you.
There's only one other thing I want to add. Sometimes in pancreatitis, which we are very often called for nutrition, if a patient comes with acute pancreatitis and you've got severe necrosis, you really don't know how long they'll be in the hospital. I would suggest that if you've got a patient with pancreatic necrosis or severe acute pancreatitis in the ICU, and if you foresee they will stay for a longer time, don't place a PICC tube. Always place a nasojejunal, because when the patient gets sick, the abdomen gets distended with ascites. They develop what we call a compartment syndrome. And when they do that, the abdomen will expand and the pig will get sucked in. And once it gets sucked in, then you've got a buried bumper syndrome in a very, very sick patient. And then on top of it, if you had fed them inadvertently, then you will have food in the peritoneal cavity, and then they have to go for a peritoneal washout and a downhill clinical course. So in severe acute pancreatitis, early on, if we don't know how the patient is progressing, nasojejunal is the way to go. Once they settle down, and on the CT scan you've developed a walled-off necrosis and you're going to treat them, that is the time to go and replace a NJ with a PICJ for longer-term nutrition when in the hospital. So any other questions for Dr. Peter? So we will, since we are running a little late, we will reconvene probably at 3:10, 10-minute break. We got fantastic speakers: chronic pancreatitis, IBD, GI bleeding, abnormal LFTs. And after the last speaker is done, after a 10-minute break, we have a little bit of a reception. You'll have some snacks and drinks, and then there'll be a talk on NASH fibrosis by our excellent hepatologist. I would encourage you to attend that as well before we wrap up for the day. So we'll take a 10-minute break and reconvene at 3:10. Thank you. G, will we get started? So we will, as everybody keeps walking in, we will start with the next session. The first topic is going to be on management of pain and diarrhea and chronic pancreatitis. How do we manage? And this talk will be by my colleague, Dr. Bang, who is working at the Advanced Endoscopy Unit at our Digestive Health Institute.
Hello, good afternoon. Thank you so much. Okay, so we're going to be talking about pain and diarrhea in chronic pancreatitis and how to manage. And I've tried to keep this talk as kind of practical as possible because it's a very difficult disease process to manage, as everyone's already aware. So quickly, chronic pancreatitis is a progressive fibroinflammatory disease of the pancreas. And the disease can be thought of as a disease continuum. The acute pancreatitis attacks act as the sentinel event of inflammation that leads to chronic pancreatitis with repeated pancreatic injury. The annual incidence is reported in the United States as 5 to 8 individuals per 100,000 adults. Prevalence in the United States is 42 to 73 adults per 100,000. These are the risk factors for chronic pancreatitis. As you can see, not surprisingly, the most common risk factors are alcohol and smoking. There was also risk of chronic pancreatitis with genetic mutations. This is reported in about 10% of cases. That includes CFTR, SPINK1, CTRC, and PRES1. The remainder of the cases are either idiopathic or they have recurrent pancreatitis, either from autoimmune pancreatitis, hypercalcemic pancreatitis, and hypertriglyceridemia-induced pancreatitis. The important thing for long-term management of these patients is that chronic pancreatitis is a known predisposing condition to pancreatic cancer, with a cumulative risk of 1.8% at 10 years and up to 4% at 20 years. So it is not insignificant. The typical clinical presentation is abdominal pain, along with nausea and vomiting, which is seen in 70% of cases. The pain is typically in the upper abdomen, and there are 3 typical patterns normally reported by our patients. Type A, which is intermittent severe attacks with or without episodes of acute pancreatitis. Type B pattern, which is persistent chronic pain in between intermittent severe attacks. And type C is the severe constant pain without attacks of pain or pancreatitis. The pain in chronic pancreatitis is attributed to peripheral and central neural sensitization, resulting in visceral sensitivity, allodynia, and hyperalgesia, and this makes pain in chronic pancreatitis particularly difficult to manage. Another aspect to think about in patients with chronic pancreatitis is to look for the different sequelae of chronic pancreatitis, most commonly pancreatic pseudocysts, stricture of the bile duct, duodenal strictures, splanchnic venous thromboses, again, risk for pancreatic cancer, diabetes, and pancreatic exocrine insufficiency. Diagnosis of chronic pancreatitis is typically made on imaging, either CT or MRI, MRCP. The typical features seen on cross-sectional imaging would be pancreatic ductal dilation, calcification, and pseudocysts. Endoscopic ultrasound remains a very sensitive and accurate method for diagnosing chronic pancreatitis. There are 9 typical criteria, and if you meet at least 5 of these criteria, then we can confidently diagnose the patients with chronic pancreatitis. This is a video of an EUS performed in a patient with chronic pancreatitis. And the echoendoscope is passed into the second portion of duodenum. And as you can see, these are the typical features. You can see the cysts, there are calcifications, irregular looking pancreatic duct. There's a stricture of the duct here, resulting in dilation of the main pancreatic duct, resulting in dilation of the pancreatic duct. And these are the calcifications that you can see going scattered throughout the pancreatic ducts. So first, we're going to talk about how to manage abdominal pain in chronic pancreatitis. As we already know, it is exceptionally difficult to manage, and I think the most important thing is to try and avoid overuse of opioids in these patients, which is extremely difficult, especially when they complain of very severe abdominal pain. But this is the typical kind of recommended approach you would take for abdominal pain in these patients. So if they have type A and type B, and these are when they have intermittent severe episodes of pancreatitis, one thing you want to look for is a structural or ductal abnormality with chronic pancreatitis, because this allows us to at least try and intervene with ERCP. If they are warranted, if they are requiring narcotics, again, minimizing narcotic use, and patients with type C, which is when they have chronic, constant severe pain, and this is when you would have to involve pain management and consider psychosocial impairments as well. The management of pain in chronic pancreatitis is you would follow the typical WHO pain ladder. The initial treatment for mild pain would be to use non-opioid analgesics, namely non-steroidal anti-inflammatory drugs, and then for moderate pain, moving up the ladder to weak opioids, and then for severe pain, you would consider, and this is commonly used, potent opioids with non-steroidal anti-inflammatory drugs, but again, minimizing regular opioid use would be advisable due to adverse events associated with opioid use, including risk tolerance, addiction, narcotic bowel syndrome, and paradoxical increase in pain due to opioid-induced hyperalgesia. Neuromodulators do have a role in management of abdominal pain in chronic pancreatitis. The most commonly used are pregabalin, gabapentin, tricyclic antidepressants, and serotonin norepinephrine reuptake inhibitors. These neuromodulators have a role as adjuncts to conventional analgesics, and pregabalin have been shown to be superior to placebo in randomized trials, and randomized trials for other neuromodulators for treatment of pain in chronic pancreatitis are unfortunately lacking. Use of antioxidants have been suggested for managing abdominal pain in these patients, and these include vitamins A, C, E, selenium, and methionine. It can be used at any stage to reduce episodes of painful attacks and to reduce the number of days with pain. And these antioxidants have been shown benefit in meta-analyses of randomized trials, and especially when they're used in combination with neuromodulators. Pancreatic enzyme replacement is also commonly used to manage pain in these patients. However, they have not been shown to be beneficial for pain control in meta-analyses. The suggested mechanism for pancreatic enzyme replacement is the action of blocking cholecystokinin receptors and diminishing stimulation of the pancreas, and may reduce bloating and cramping, but the evidence is still lacking for use of pancreatic enzymes for controlling pain specifically. Another alternative is to perform EUS-guided celiac plexus block. This involves, under EUS guidance, injecting a local anesthetic agent, usually bupivacaine, 0.25%, followed by 80 milligrams of triamcinolone at the takeoff of the celiac artery from the aorta. In meta-analysis, it has been shown to result in alleviation of abdominal pain in 50 to 76% of patients, with duration of effect lasting 3 to 6 months. The side effects are acceptable and not common, and can include postural hypotension and diarrhea. If the patient has a pancreatic pseudocyst as a complication of chronic pancreatitis, depending on their symptoms, especially if it's causing abdominal pain, it should be drained. Right now, the standard of care and gold standard is to drain these pancreatic pseudocysts under EUS guidance by placing either plastic or metal stents, usually from the stomach or the duodenum, depending on the location of the pancreatic pseudocysts, to help the patient with pain and sequelae of pancreatic pseudocysts. And this is just a video of us placing plastic stents in a patient with pancreatic pseudocysts from chronic pancreatitis. Essentially, the pseudocyst punctured using a 19-gauge needle, a guide wire inserted inside and allowed to coil several times. The tract is then dilated, and this allows us to place, in this case, plastic stents into the collection. ERCP also has a role in chronic pancreatitis, and this is indicated for treatment of pancreatic duct obstruction, as pancreatic duct hypertension is considered to be the etiology of the pain. So ERCP in chronic pancreatitis would be indicated in patients with pancreatic duct stones, so that we can remove pancreatic duct stones and also dilate any pancreatic duct strictures, along with stent placement. Patients with pancreatic duct leak can also benefit by us placing a pancreatic duct stent, and this is considered first-line intervention for patients with moderate to severe pain resulting from pancreatic duct obstruction, and can help with pain relief in 70% of patients. Next, the last resort would be surgery, and this is for patients with persistent pain despite medical and endoscopic therapy. And the whole purpose of surgery in chronic pancreatitis is to drain the obstructed duct and to resect areas of chronic inflammation or areas suspicious for malignancy. The response rates have been reported anywhere from 50 to 80%, and the success is not 100% and not universally beneficial in patients, likely due to central pain sensitization and residual disease in remaining unresected pancreas. Now, these are all the possible surgeries that can be performed, but the types of surgery will depend on whether the patient has dilated or non-dilated pancreatic duct. For patients with dilated pancreatic duct and therefore pancreatic duct obstruction, the commonly performed surgeries are lateral pancreaticojejunostomy, also known as Pusto's, or lateral pancreaticojejunostomy with localized pancreatic head resection if they have a poorly drained head of the pancreas along with pancreatic duct obstruction. For patients with non-dilated pancreatic duct, these are all the options, but basically resection of the head of the pancreas, so pancreaticoduodenectomy. Duodenum-preserving pancreatic head resection can also be performed, that's known as Burgess syndrome. Distal pancreatectomy if there is localized small duct disease in the tail of the pancreas. And then lastly, total pancreatectomy with or without autologous islet cell transplantation. This will be for patients with diffuse parenchymal involvement with debilitating abdominal pain, but this unfortunately is associated with high rates of diabetes and pain relief is not guaranteed. Now, our next topic is going to be on pancreatic exocrine insufficiency. Now, each individual symptom that patients report is not sensitive or specific for steatorrhea. So patients will often complain of diarrhea, so loose stools, bulky or foul-smelling stools, stool that's difficult to flush, and pale or oily stools. Reduction of the symptom with pancreatic enzyme replacement actually strongly supports the diagnosis of steatorrhea. And the diagnosis of exocrine pancreatic insufficiency is usually through fecal elastase 1 measured in a single stool sample. An abnormal value will be less than 200 microgram per gram of stool, or quantitative fecal fat measurement by collecting stool over 48 to 72 hours on a diet of 100 grams of fat a day. Abnormal value is 7 grams per 24 hours. The treatment of pancreatic exocrine insufficiency is with pancreatic enzyme replacement. Now, this is porcine in origin and is most of the available replacements are coated to delay degradation by a gastric acid. The indication for using pancreatic enzyme replacement would be if your patient has classic symptoms of steatorrhea, if they have suggestive symptoms of steatorrhea plus low fecal elastase, or they have suggestive symptoms of steatorrhea with fecal fat greater than 15 grams per 24 hours. The starting dose is usually 20 to 50,000 USP units per meal, and the ideal dosing is 500 units per kilogram of body weight per meal, taken with first bite of each main meal and half the dose with snacks. And the maximum dose of pancreatic enzyme replacement you can give is 2,500 units per kilogram of body weight per meal. Common mistake made in patients with pancreatic insufficiency where the patient's not achieving any benefit from pancreatic enzyme replacement is usually a dose of pancreatic enzyme supplements that's too low. So one thing you really want to remember is to maximize efficacy. Make sure the patient takes the replacement with meals. Make sure the patients are distributing their calorie intake over 4 to 5 meals per day. Use acid-reducing agents, and then also testing for and treating small bowel bacterial overgrowth, which can cause similar symptoms. And then right now it's a good idea to avoid fat restriction because it can actually result in weight loss and deficiency of fat-soluble vitamins and essential fatty acids, which can actually be detrimental for your patient. For refractory symptoms, again, consider inadequate dose of pancreatic enzymes, non-compliance, acid denaturation of enzymes, and alternative causes of maldigestion or malabsorption, such as small bowel bacterial overgrowth. So in summary, abdominal pain is a common symptom in chronic pancreatitis. We should try and avoid use of opioids, or at least minimize its use, and consider addition of neuromodulators for you to achieve that purpose, such as pregabalin and gabapentin. EOS-guided celiac plexus block can provide pain relief for 3 to 6 months in up to 75% of patients, and ERCP is effective for pain relief in patients with pancreatic ductal obstruction. Surgery is indicated for patients with refractory pain not responding to medical therapy. pancreatic enzymes replacement should be used for patients with steatorrhea, and inadequate dosing is a common reason for persistent steatorrhea in your patients with chronic pancreatitis. Thank you very much. The questions. Okay, so this is our first question. We have two questions. So our first patient is a 63-year-old male with history of smoking and daily alcohol intake, admitted with worsening episodes of abdominal pain for the last 6 months. He also has a history of recurrent acute pancreatitis with, on average, 2 episodes per year for the last 5 years. He was managed by his primary care physician with ibuprofen, acetaminophen, and oxycodone for the last 3 months, but the patient's having persistent pain. CT of the abdomen pelvis done in the ER shows pancreatic atrophy, pancreatic ductal calcification in the head of the pancreas, and a dilated pancreatic duct measuring 9 millimeters in diameter. So what would be the next best step in management? 1, increase the dose of oxycodone. 2, start pancreatic enzyme replacement therapy for suspected steatorrhea and also for pain control. ERCP for ductal stone extraction and stent placement. Refer to pancreatic surgery for pancreaticojejunostomy.
What was polling?
That's correct. Option 3. This patient clearly has ductal obstruction because we can see calcifications on imaging and there is dilation of the pancreatic duct. So the most helpful treatment in this patient would be to perform an ERCP, remove some of the stones, dilate any strictures, and place a stent as necessary. This is our second question. A 48-year-old male with chronic pancreatitis presents to clinic with a 6-month history of loose, foul-smelling stools and weight loss. Fecal elastase was measured, which was consistent with pancreatic exocrine insufficiency. He was started on pancreatic enzyme replacement at a dose of 25,000 units TID with meals, and his weight during the clinic visit was 78 kilograms. He sees you in 6 weeks, but he says that there is no improvement in symptoms at all, and he has persistent, loose, foul-smelling stools, which he's very unhappy about. What is the next step in management? Perform an MRI of the abdomen, start trial of pregabalin, increase the dose of pancreatic enzyme replacement, or 4, change to non-enteric-coated pancreatic enzyme replacement. Oh, that's very good. Yes, so we would increase, his weight was 78 kilos, and you would want to multiply that by 500 to get the ideal dose for that patient for each meal. So he's clearly underdosed, so that will be the most simple and probably the most effective thing you can do to help this patient. Thank you. That's it.
Do we have any questions for Dr. Bang before she leaves? So one of the common things that not many are aware of is there is a treatment available for small duct disease, chronic pancreatitis, to which the patient does not respond very well to treatment. So from there you go on a slippery slope. But they have got severe pain, you do a MRI, you just see some lobulations on a CT scan and a MRI, and then there's nothing that we can offer on endoscopy. So these are the patients who typically will graduate from NSAIDs to low-dose narcotics, and then they are lost. And then they are the patients who will ideally land up on fentanyl and other types of problems. So before they get to the stage, what you want to do is to do 2 things. 1, to refer them to a medical pancreatologist if you can. And the reason you want to refer them to a medical pancreatologist is to create a conduit to go to a place where they will offer total pancreatectomy with islet cell transplantation. This is not a surgery very commonly done in Florida. It's done in Miami, I don't think it's anywhere done in Central Florida, the other centers, UAB and so on. But this is a valid treatment. Patients will do well. There's one caveat. If you are a diabetic, then this is not an option that's available. So you don't want patients to go through a slippery slope, become a diabetic, and become narcotic dependent. You need to grab them early and get a consultation and a paperwork moving like what we would do for our organ transplantation. So thanks, G. Okay.
Thank you. Thank you very much.
So we will go back again to Dr. Agarwal, and in 20 minutes, she's going to teach us all that we need to know about IBD.
Right, Dr. V, I've accepted your challenge. 20 minutes, let's go. So we'll talk about IBD 101, pathophysiology, diagnosis, and initial therapy of IBD. Our objectives are to discuss the pathophysiology, epidemiology, diagnosis, management, and care of patients with IBD. And so inflammatory bowel disease is an umbrella term, and it gets divided into two main diseases, Crohn's disease and ulcerative colitis. And I'll go into talking about each of these two disease processes in the upcoming slides. There is a third term called IBDU, or inflammatory bowel disease unclassified, in which it's difficult for us to distinguish whether the patient has Crohn's disease or ulcerative colitis, but that's not what my talk will be about predominantly today. So IBD can affect children as well as adults, and roughly 1% of the US population has inflammatory bowel disease. There is a bimodal distribution of the incidence of IBD, with most of the cases occurring in the second and third decades of life, with a smaller peak occurring at the age of 50 to 60. The next point I want to make on the slide is that with industrialization in the 19th century, the incidence of IBD rose in the Western world, and during that time, it was relatively uncommon in the Eastern countries, with the first case of ulcerative colitis being described in 1950s in China. Since then, the incidence of IBD has increased in newly industrialized countries in the East, and we think that the incidence is increasing in the East because of improved access to healthcare, more awareness of the disease, changes in the diet to a more Western diet, which then leads to a change in microbiome. Interestingly, though, there's a paradigm shift where the incidence of IBD is actually stable or decreasing in the West, and again, rising in the East. So what causes IBD? Well, to be honest with you, we don't really know the exact answer to this. We think that there are two main reasons why patients get IBD. One is there's a genetic component, and two, there is some sort of change in the microbiome that leads to the development of IBD. So the principal theory of IBD states that in genetically predisposed individuals, certain environmental stressors such as smoking or an infection or something in the diet leads to an uncontrolled inflammatory response that leads to IBD. And this is supported by the fact that certain populations, such as the Ashkenazi Jewish population, we see an increased incidence of IBD in that group of people. Another theory is that there is some kind of dysregulation that happens in the microbiome due to some sort of stress, again, diet or medications, etc. And this dysregulation in the microbiome then leads to an abnormal immune response, and that ultimately triggers the development of IBD. And as mentioned, this is sort of what we're seeing in the Eastern countries, where the diet is changing to a more Western diet, and the incidence of IBD is increasing. My personal opinion is that it's not necessarily just genetic or just microbiome. There's some complex interaction that we don't fully understand between genes, microbiome, and environmental stressors that ultimately lead to development of IBD. So now let's talk about what the differences between ulcerative colitis and Crohn's disease are. So ulcerative colitis affects mostly the colon. That's why the name is ulcerative colitis. Rarely, patients can get inflammation in the terminal ileum when the right side of the colon is involved as well. And that's called backwash ileitis. So the stool sort of backwashes from the right side of the colon into the ileum and can lead to mild inflammation in the ileum. Another difference between ulcerative colitis and Crohn's disease is that patients with ulcerative colitis will have continuous inflammation. So you can see in the picture from the right, patients had inflammation stretching from the rectum all the way to the transverse colon, as opposed to the middle picture where patients had inflammation in patchy distribution. That's a patient with Crohn's disease. Crohn's disease can affect patients anywhere from the mouth to anus, but predominantly affects the terminal ileum. So 60% of patients will have inflammation in the terminal ileum. Now, on pathology, you can see differences as well. So the GI tract is divided up into 4 different layers: mucosa, submucosa, muscularis, and serosa. Patients that have ulcerative colitis tend to have inflammation just involving the mucosa. And Crohn's disease patients tend to have transmural inflammation, which we see that the inflammation involves all 4 layers of the GI tract mucosa. So how do we diagnose Crohn's or ulcerative colitis? Well, it's actually a clinical diagnosis, and no single test will give you the answer whether the patient has inflammatory bowel disease or not. We start out with routine lab testing with CBC, CMP, and CRP. Oftentimes I get referral in my clinic where providers have tested for IBD serologies, and I don't recommend testing for that. IBD serology do not diagnose IBD. All they do is help us understand what the disease course will be for a patient that already has a diagnosis of IBD. So for example, you have a patient with Crohn's disease and you're checking a serology and the anti-cerevisiase Saccharomyces antibody comes back positive. That can give you an idea that the disease course will be more severe for the patient, but it does not diagnose IBD. Other things that we test for is stool testing. We get imaging with enterography. So what is enterography and how does it differ from a traditional CT? Well, an enterography is where patients will be given an oral and IV contrast, and it actually images the patient from the luminal side to the serosal side, as opposed to a standard CT, which is imaging patients from the serosal side going inwards. And this is important because IBD actually affects patients from inside the GI tract going outside, so it's a great test to look for inflammation. CT enterography is equivalent to MR enterography. Typically in young patients, you want to avoid radiation exposure, especially because they are going to be getting imaged pretty routinely. So I tend to go with MR enterography. But if they're claustrophobic and it can be a little bit more expensive, then CT may be the only choice. Intestinal ultrasound is becoming very popular to evaluate for colonic disease. We are lucky at Orlando Health IBD Center. We have our own intestinal ultrasound, and we're able to, in clinic, in real time, assess the intestinal lumen to see if there's inflammation or thickness. This is great because it's fast, it's low cost, it's right there. The patient is in clinic. We just put an ultrasound probe and we're able to see it, and it's radiation and dye free. Endoscopy still remains the gold standard for diagnosis. Typically, patients will ask me if they need to get an upper endoscopy as well. Generally not, unless they're having symptoms like abdominal pain, dysphagia, iron deficiency. You also need to have pathological confirmation. So on the pathology slides, if it's mentioned as just acute inflammation, that does not diagnose IBD. You need to have chronic inflammation because acute inflammation can come from lots of different things like infections or ischemia, but it's the word chronic inflammation that gives you the diagnosis of IBD. In patients with ulcerative colitis, you may read words like cryptitis or cryptapsises. That is also a marker of chronic inflammation. And in patients with Crohn's disease, The clincher is granulomas, and we're always looking for that word. However, it's actually present in less than 30% of patients. So just because the pathologist did not see a granuloma, that does not mean they don't have Crohn's disease. There are numerous classification systems for patients with IBD. One of them is the Montreal classification for adults or the Paris classification for peds, and they take into account the age of diagnosis, the location of disease, the type of disease the patient has, and how it's affecting the patient's growth. This is the type of endoscopic score I like to use in patients with ulcerative colitis. It's called the Mayo score, and I'll go over it with you guys. So in the first column, where it's bluish green, that's a normal, healthy colon. That's a Mayo score of 0. That's what we're always trying to achieve in patients with ulcerative colitis. So in the next column over in the yellow, that's mild disease. That's Mayo score of 1. And patients will have erythema, decreased vascular pattern, and some friability. In the next column over in pink, you see more moderate inflammation. This is Mayo score of 2. Patients will have a little bit more erythema, absent vascular pattern, and erosions. And in the last column in purple, you see very severe disease. This is Mayo score of 3. Patients will have spontaneous bleeding and ulceration. So the way you can remember this is Mayo 1, erythema, Mayo 2, erosions, Mayo 3, ulceration. This is a representative image of patients with Crohn's disease. Patients with Crohn's disease often have deep ulcers, as you can see on the left. They can also have pseudopolyps and nodules in a term we call cobblestoning, and that's seen in the middle picture. And then they can also have deep punched out lesions with intervening normal mucosa, and that can also represent skip lesions. A way to grade Crohn's disease endoscopically is with the simple endoscopic scoring for Crohn's disease, or the SES-CD score. This scoring system takes into account inflammation in the ileum, right colon, transverse colon, left colon, and rectum. 4 criteria are used when we're grading these patients, such as the size of the ulcer, extent of the surface covered by ulcers, extent of surface covered by other types of inflammation like erythema, and the presence of stenosis. The next type of scoring system is the Rutgert scoring system, and this is a scoring system used in patients that have undergone ileocolonic resection with an ileocolonic anastomosis. So picture A, that's a normal, healthy-looking ileum. That would be a Rutgert score of I0. Picture B may be a little bit difficult to see, but there are some ulcers there, tiny ones, aphthous ulcers, and there's less than 5. That's Rutgert's I1. Picture C, there are more ulcers, and typically it's more than 5, and that's Rutgert's I2, and this is when we start to initiate biologic therapy or advanced therapy for patients. So when they have I0 or I1, we kind of watch it, especially I1, typically I'll have my patients come back in a year for another scope, but once they've progressed to I2 and above, we decide to start more advanced therapies. Picture D is showing more diffuse ileitis with inflamed mucosa and deeper ulcers, which is Rutgert's I3. And then lastly, picture E is your Rutgert's I4 with, again, more severe inflammation. So there are multiple mimickers of IBD, and those have to be ruled out before you give a diagnosis of Crohn's or colitis to a patient. Mimickers can range from infections to other autoimmune conditions such as sarcoidosis, immunodeficiencies can cause it, and malignancies or diverticulitis. So it's important that patients get the correct diagnosis so that they can be treated appropriately. So what are some of the signs and symptoms? Patients will often present with diarrhea. If they have colonic inflammation, they'll present with rectal bleeding, abdominal pain, fatigue, and weight loss. There are a number of complications that patients can have when they have inflammatory bowel disease. With patients with ulcerative colitis, one of the most feared complications is toxic megacolon, and actually in my 2 years, I've seen one case already. This is a surgical emergency, so patients really just need to go to the OR to get a colectomy because no medical management is going to help at this point. Patients with Crohn's disease can develop strictures, fistulas, have problems with malabsorption, can develop kidney stones, and both diseases often result in dehydration, nutritional deficiencies, and if left untreated, malignancy and perforation. So I can spend an entire 20 minutes talking about extraintestinal manifestations of IBD, but I'll keep it very brief. So patients can get inflammation involving other parts of the body as well, particularly the skin, the joints, and eyes. Most patients with IBD, the most common extraintestinal manifestation is joint pain, but others can happen as well. When choosing an advanced therapy, like a biologic or a small molecule, you want to choose something that will target both the GI tract illness as well as their extraintestinal manifestation. So for example, if they're having skin issues, a good choice would be something like risankizumab or ustekinumab, which will target both skin issues along with their GI tract issues as well. So there are many different treatment options for patients with IBD, and treatment really depends on how severe their disease is, whether it's mild or more moderate to severe, and whether they have Crohn's disease or whether they have ulcerative colitis. Mild ulcerative colitis can be treated with aminosalicylates, and in general, we think that combination therapy of both oral and topical aminosalicylates works the best, especially in patients with left-sided ulcerative colitis. So this is how I explain it to my patients. Aminosalicylates work almost like lotion. They work topically. So when a patient has left-sided colitis and they're just taking the mesalamine product by mouth, by the time it gets to the left colon, a lot of it's already digested, so their left colon is not getting the medication. So then you have to give them topical medication in the form of an enema or a suppository so that they're getting the combination oral and topical to really get that good healing of the mucosa. Mild Crohn's disease is a little bit difficult to treat because, to be honest, we don't really have great treatment options. Mild Crohn's disease can be treated with intermittent steroids like budesonide, or you can consider dietary modification. I recommend Mediterranean diet in addition to turmeric or green tea extract to see if that helps heal the inflammation. Mild Crohn's disease definitely needs to be monitored endoscopically to make sure it's not progressing to more moderate to severe. And when patients progress to moderate to severe disease, that does require advanced therapies in the form of biologics and oral small molecules. There's lots of different options out there. I won't go through each and every one of them, but just keep in mind there's many options, and as research develops, more and more options are coming out. What is the difference between biologics and oral small molecules? So they're both immunosuppressing drugs that target different cytokines or different molecules within the body. But the key difference is that biologics are given via injection or IV, and that's because they're large molecules. So if a patient was to take it by mouth, the GI tract won't absorb it. So that's why they get it via injection or IV. In opposition, oral small molecules are tiny. They can be absorbed when patients take it by mouth. So that's kind of the main difference between the two. These medications do come, when you choose advanced therapies, they do come with side effects, such as possibility of an injection or an infusion reaction, infections, small possibility of malignancy, blood clots, cardiovascular events. So it's very important once they get started on these drugs that patients are monitored and they're given by an experienced gastroenterologist or an inflammatory bowel disease specialist that's comfortable in dealing with these drugs and some of the side effects that can occur. After starting advanced therapy, it's important to perform endoscopy and/or imaging typically 6 months afterwards, to make sure the patients are responding to the drug. Don't just go by symptoms, because symptoms can be deceiving. Patients can say they feel great, and that could just be a placebo effect. So it's very important to get objective assessment via endoscopy. And then, like I mentioned, because of the side effects, it's important to check labs and have the patient come in for routine clinic visits just to make sure they're doing okay on the medications. So surgery is also one of the management options for patients with IBD. Surgery, we often think of surgery as patients that failed treatment, and that really we should throw that out of our minds. Surgery is a treatment option and not a treatment failure. So to be honest, like if patients, they don't want to be on lifelong medications, you can offer surgery to them, and if you have an experienced surgeon, they might consider it. But in general, we consider surgery for patients that are not responding to medications, have complications like toxic megacolon or perforation, severe ulcerative colitis, severe hemorrhage, dysplasia or malignancy in patients with UC. In patients with Crohn's disease, on the other hand, we consider surgery if they have strictures with obstructions, fistulas, abscesses, perforation, malignancy, etc. So just a little bit more on surgery. So in patients with ulcerative colitis, colectomy is curative. They end up with an end ileostomy. But sometimes that's not acceptable to patients, and they want to go back to having a normal function of bowel anatomically. So patients can be considered for something called an ileal pouch anal anastomosis, which is a 2 to 3 stage surgery in which the ileum is formed into a pseudocolon called a pouch, and this could be a good option for patients. However, 40 to 50% of patients who undergo ileal pouch anal anastomosis develop some kind of inflammation called pouchitis. Most of the time, the pouchitis can be managed with antibiotics for a 10 to 14-day course, and even probiotics. However, some patients develop chronic pouchitis, which may require long-term antibiotics, or even unfortunately go on to developing Crohn's-like phenotype of the pouch, which would then require advanced therapy like biologics. Now, pregnancy and IBD. This could be, again, a lecture on itself, but these are sort of the take-home points with it. Healthy baby, healthy mother equals healthy baby. So what that means is that in patients with moms with active disease, that increases the risk for adverse maternal and birth outcomes. So when moms have active disease, there's a higher rate of miscarriage, lower birth weight, increased risk for preterm delivery. So it's very important that moms get remission 3 to 6 months prior to conception. Now, IBD medications are generally safe during pregnancy, conception, and even postpartum. Most biologics, monoclonal antibodies, are okay to use during pregnancy, and it's also okay to breastfeed on them. The exception to advanced therapies would be anything oral, so methotrexate, your JAK inhibitors, or your S1P receptor modulators. They're not safe, so we recommend stopping them 3 months prior to conception. If patients are on azathioprine or 6-MP prior to conception and they've done well, it's okay to continue it. However, I recommend not starting it during pregnancy because there is a low risk for pancreatitis, so you don't really want to have a pregnant patient with pancreatitis. But if they've done well on it, totally okay to continue. Prednisone is also okay to use. I initially was a little reluctant to use it during the first trimester because there is small studies that show increased risk for cleft lip or palate in the baby. However, when you talk to MFMs, they're very comfortable with it and it should be okay to use. If patients have questions about biologics and conception and pregnancy, there is a registry called the Piano Registry, which is based out of UCSF. The head is Dr. Uma Madhavan, and she has thousands of mothers with ulcerative colitis or Crohn's disease that have been treated with biologic therapies. And like I mentioned, by and large, they're pretty safe. The study has found a few key points. So the first key point is mothers on steroids during pregnancy had a higher rate of preterm birth, low birth weight infants, and more infants were admitted to NICU. So again, very important that moms are in remission prior to conception. Biologics can cross the placenta, so when moms are on biologic therapy, we recommend that the infant not get live vaccines for the first 6 months of life. Levels of biologic in breast milk are very minute, so it's again okay to breastfeed while on biologic therapy. There's no increase in infections at 4 months or 12 months if an infant was exposed to biologics or thiopurines during pregnancy. And there has been no differences in infant developmental milestones, whether the baby was exposed to biologic or not. Last thing I want to talk to you about is healthcare maintenance. So patients on immunosuppressive therapy should undergo routine healthcare maintenance. Vaccinations should be checked at every clinic visit. Obviously, they need to be screened for colon cancer. There is a slight increased risk for cervical cancer and skin cancer, so appropriate referral to GYN and dermatology is important. Screening for osteoporosis is important because patients have been on steroids very often, especially if they've taken steroids for more than 3 months continuously. A DEXA scan would be appropriate. Screening for depression and anxiety is important because IBD is a very tough disease. Patients are having a lot of pain and diarrhea, so it's important to check for that. At our center, we have a dedicated IBD clinical psychologist who's available to all our patients, and she offers great counseling. Tobacco cessation and guidance is also important, and yearly checking for latent TB and hepatitis B if they're on biologic therapy is also recommended. So I will finish by asking our question. We have a 23-year-old male with 3-month history of rectal bleeding and diarrhea. He is a former smoker and recently quit smoking. He undergoes a colonoscopy which shows Mayo 1 mild left-sided ulcerative colitis. Which of the following treatment regimens would you consider for this patient to induce and maintain remission? Exactly. So most of you got it correct. Like I mentioned, oral and topical combination therapy is best, but we can go through each of the options. So resume smoking is never an option. Never pick that. There are some studies that show in UC patients smoking is protective, but we always counsel them to stop smoking. Oral corticosteroids, a good option, however, that's only going to induce remission. It's not a good option for maintaining remission. Trial of upadacitinib, that's an advanced therapy, that's a small molecule. Typically, advanced therapies are offered for patients that have moderate to severe colitis. This patient had more mild colitis. And further, it's not a great option because the FDA recommends that patients fail anti-TNF prior to trying a JAK inhibitor like upadacitinib. And so now between oral and topical mesalamine and oral mesalamine, because this patient had left-sided colitis, remember, combination therapy with oral and that addition of suppository or enema is going to get the best coverage for the patient's mucosa, resulting in healing.
Fantastic. So before we let Dr. Agarwal go, does anybody have any questions on IBD? Okay, even I got the question right, Mitali. Thank you. Thanks so much. So we'll go to the next talk, and I'm going to invite Dr. Peter, again from UAB, to talk about GI bleeding, how to assess severity and manage it appropriately. Since we don't have self-assessment, we are still very good on time.
Thanks again, Shyam. I'm going to go a little quick on these slides because it covers a big topic for GI bleeding. This is something we are going to be seeing very commonly in our practice, right from the ED to inpatients to outpatients. So let's see how we can approach this. Definitions of GI bleeding. risk stratification of GI bleeding, what is the current management strategies and timing for intervention, and let's elaborate a little bit on the daily practice using an algorithmic approach. The epidemiology, you see bleeding has been coming down, fortunately. The PPIs have taken over, and what we used to see 10 years back, the bleed rates are much lesser now. But remember, there are still bleed variceal versus non-variceal bleeding, and the non-variceal bleeding still accounts for 10% mortality. Variceal bleeding, with increased NASH and the liver disease going there, if you have a 30% of varices will bleed within the first year, so that accounts for 33% mortality with each bleed. Lower GI bleeding is much more less common than the upper GI bleed. Other definitions that are acute GI bleeding presents with hematemesis, melena or hematochezia, severe when it's hemodynamically unstable, overt when you see visible signs of blood loss. Hematemesis equals to upper GI blood bleeding. Melena, if it's more than 50 ml of blood, it could result from upper GI bleeding also, but could be in a source from anywhere, small bowel or proximal colon. When you see hematochezia of fresh blood per rectum, that usually suggests a lower GI bleeding. This slide tells you exactly where the majority of bleeds happen. The upper GI tract, 85%, esophagus, stomach, duodenum. Lower GI, the colon, 10%. And the middle tract, this is the small intestine, the long area, around 5%, but these could be the most difficult and costly bleeders. In the upper GI bleeding, let's tackle this first. Most of the causes are ulcers. That's what you see most of the time, ulcer disease. And then followed by gastroesophageal varices, which is liver-related. But it could be other causes. There are multiple causes, ranging from benign tumors to malignant tumors, duofoils, etc. Initial assessment, you want to know the age. The more age, the more riskier the patients are, previous bleeding, comorbidities, especially people with cardiac diseases, heart failure, AAA repairs, cirrhotics, previous endoscopies, look at the reports. They may have had an ulcer bleed in the past or some other significant clue to tell you where the bleed source is. Associated symptoms like anorexia, weight loss, nausea, vomiting, hemoptysis, and medications. This is where we're going to be seeing a lot more patients with anticoagulation therapy, the dual platelets, NSAIDs, warfarin, etc. Clinical evaluation, obviously symptoms, as he had diarrhea, anemia, the overt signs of bleeding. Vital signs, look very carefully for examination. Is he stable or unstable? DRE is an important thing. We often miss that as an important examination, but do a DRE to see if there's fresh blood or not. Sometimes it could act as a real triage tool in the ED. If you see blood or brown stools, you know this patient is stable. If any complaint of stools, blood in the stools. Weak pulses, cool skin, encephalopathy will tell you something about liver disease. The key elements of management of upper GI bleeding is initial management, stratify risk, triaging a patient when he comes through the door, what are the diagnostic modalities, and how do you post-management and prevention of these strategies. So risk scoring, I mean, this is a broad kind of thing, but there are certain important risk scorings that we need to keep in our mind. This is a common risk scoring. This is the GBS score, the Glasgow-Blatchford score. It uses these kind of points, hemoglobin, BUN, systolic rate, heart rate, syncope, and then you make a composite score anywhere between 0 to 23. Anything that goes up or climbs up is a risk for higher scores. This is a Rockwell score, which is a much more larger score. It has pre-endoscopic and post-endoscopic calculations. So if you see as the patient's age goes up, his hypotension happens, there's more fresh bleeding, and you see active signs of bleeding on endoscopy, the risk is clearly higher. And if you have a total score or 0 to 11, low risk less than 2, 3 to 5, or high risk more than 6. Another simpler score is an AIM-65 score, which is a bedside score. You can use albumin, INR, these calculations, altered mental status, systolic less than 3, and age. And then you put a composite score 0 to 5. A score of 0 has a mortality of 0.3%, but then it goes up if you have a score of 5. is 31%. So these scores give you an idea, basically, this patient really high risk or not. So once you see a patient, then what you want to do, you want to make sure you stabilize the patient, and then you want to transfuse the patient. Now, there's some important caveats for transfusion. So in this study, a beautiful study which shows restrictive strategy versus a liberal strategy. So you just keep on transfusing blood, and you see basically the survival of a patient is much better in a patient with a restrictive strategy than those with a liberal strategy. So you want to keep the hemoglobin around 7. Above 7, we really don't need to transfuse, except in certain situations like pre-existing cardiovascular disease, coronary disease. You want to keep the hemoglobin around 8 grams. Use of PPI. Now, should we just give every patient PPI? Is there a role for it? There are some studies which show that there is a mild difference that PPI helps in prevention of further bleeds, or a difference of around minus 3% beneficial in the terms of PPI. It does not really change clinical outcomes with further bleeding or death. So there's no clear recommendation for endoscopic PPI therapy, but you can give it if patient has been there delayed, or you need or EGD is not done within the time you can put them on PPI. Do you need to give it bolus versus infusion? This study shows that there's slightly more favor for bolus infusion, so it doesn't matter, but you can put bolus infusion and give them PPI that way. So the current concepts are risk assessment, stratify based on what we discussed, triage a patient, stabilize a patient, transfusion strategy based on hemoglobin levels, target the INR in patient. Look for the INR less than 2.5. You want to target an INR for that. Now, this is another important one. Do you put every patient NG lavage or not? They're really not required. Actually, there are studies that show NG lavage can be harmful, especially if you have a variceal bleed. And there's not any benefit giving you putting an NG lavage. There is a benefit of giving IV erythromycin. So if you give 250 milligrams over 30 hours, 1 hour before an EGD, it kind of clears the stomach. So when you go with an endoscopy, you can easily visualize the thing. So keep that in mind. If you have an acute bleeder, you have the time, and the patient has no contraindications, IV erythromycin. Timing as endoscopy is the next important thing. Do you need to do it early or late? And these studies, really good studies, randomized studies, show that there's no difference. Actually, the mortality is higher if you do a patient within the first 6 hours or 8 hours. So you just you don't have to push a patient. You might get a push from the ward service, or it's on a patient comes on a weekend, the night. If the patient is stable, you can actually do it within the next 24 hours. You don't have to really push and do an endoscopy, unless the patient has a variceal bleeding or suspected in that situation. The therapeutic options, this is just a whole bunch of things that we can use for treatment. Just to keep you in your mind, there are injections. They can do thermal. You can use it with heater probe. You can use clips like mechanical or bandings or bear claws. And the risk of ulcer. So this is the important thing. If you have an ulcer with an active bleed, which we call Forest 1, low risk is Forest 3. A high risk with an active bleeder, the risk of rebleeding is 55%. It goes down to 5%. But the first Forest 1 or 2 or B, 2A or 2B are something that could rebleed, and you want to make sure there's good therapy for these patients. What are the therapy? You can offer them endoscopic hemostasis, as I mentioned, or a combination to treat these visible vessels or what you see endoscopically. These are the guidelines from ACG, and they say there's a strong recommendation for heater probe, electrocoagulation, though the data is a little less for through-the-scope clips or other modalities, but a combination with epinephrine along with another combination has a strong recommendation. So a combination therapy is usually what we try to look for in treatment of GI bleeding endoscopically. This slide would tell you how you treat an active bleeding. So a patient comes active bleeding, endoscopic therapy, PPI, clear liquids 2 days, hospitalized 3 days, discharge. If you're an adherent clot, then you just, you can give endoscopy treatment, PPI, clear liquids, 3 days hospitalized. If you have a flat pigmented spot, which is a lower risk of forest, then no endoscopy treatment is really needed. Just PPI, clear liquids, hospitalize 1 or 2 days, monitor, and you can discharge. If you have a clean base ulcer, actually, no endoscopy therapy, PPI daily, and you can discharge them home actually after the endoscopy is done. Variceal bleeding, I'm not going to go too much into detail with variceal bleeding, but if you have an acute episode of this, can be really dramatic. They are much more sicker patients. You want a few key things. You want to give them antibiotics, ceftriaxone for maximum of 7 days, octreotide infusion for at least 2 to 5 days. And the treatment, usually what we do is EBL or endoscopic variceal ligation, which will easily take care of these varices. But remember, failure can happen. In that situation that you want to consider doing a TIPS or call the IR to help you with that. And prevention is also important, that you want to start them on a non-selective beta blocker. This is a little more, I'm not going too detailed in this, but just giving you an idea of some key elements or points of variceal bleeding. There are some overlooked lesions that you need to know that they could be missed on a first endoscopy. For example, Cameron's lesions are those sitting inside a hiatal hernia. Fundal varices can be missed. GAVE, or what is called gastric enteral vascular ectasia, could be missed, just thought about to be just gastritis. So these are important lesions. This is actually a patient of ours who came with a pancreatic cyst adenoma of the head, which is protruding into the duodenum and actually was bleeding, and was actually missed on the first endoscopy. So briefly, an algorithm here. This is a little busy, but I think you risk stratify based on the GBS. Let's take the GBS score. If a high GBS score, high risk, make sure you get IV bore lines, 2 lines at least, stabilize the patient, start them on PPI, triage them, and then decide when to send them for endoscopy. If it's a variceal bleed, then that algorithm goes into variceal bleed direction. If it's a non-variceal, based on the stigmata, what you see, if it's a low-risk stigmata, you can admit them or discharge them straight away, put them on PPI. If it's a high risk, then you need to admit them, monitor them till you have definitive therapy done within the first 24 hours. After treatment, also important that you need to treat them for H. pylori. If they have NSAIDs, biggest culprit, discontinue it. Decide on a COX-2 selective, like meloxicam, for example. You can stop the temporarily aspirin and restart it. And long-term PPI can be considered for some patients. Briefly into lower GI bleeding, and this is basically meant multiple causes, but I think the commonest thing that we see the source is diverticulosis, causing lower GI bleeding. The key concepts of management of lower GI bleeding. Now, 80% of them, like divertical bleed, will resolve spontaneously. 30% can rebleed. The traditional approach has been elective colonoscopy after resolution of bleeding. It has a low therapeutic benefit because you may not see the lesion anymore. You can also do the other approach is an urgent approach. But actually, in a stable patient with lower GI bleeding, the ideal approach is plan for an elective colonoscopy at the next available opportunity after an adequate bowel prep. If you have an unstable patient, you might as well want to do a CT angiography, which will localize the bleeding and then proceed with IR. This is the same algorithm that just mentioned what I talked to. Surgery will be the last resort if you can't fix it by either of these mechanisms. Lastly, I'll briefly talk about obscure GI bleeding. And this is a difficult scenario because you looked at upper, lower, you still don't know where it's bleeding. And then you know there's somewhere else it's bleeding, which most of the time is small intestine. It could be overt, where you have visible blood, or occult. There are different modalities for testing, which could be barium is pretty much not done. Push enteroscopy, where you use a longer scope and seeing into the proximal small bowel, CT, nuclear scans, capsule endoscopy, or device-assisted enteroscopy we'll talk about. The management, the first line management is a video capsule endoscopy, which excludes, it runs through the entire small intestine, and it's able to give you a clear idea where the bleeding is. The yield for that is almost 60%. The next yield is you could do other imaging like a CT. And the important concept for this is the earlier you do it within the first 24 to 72 hours, the better your yield of picking it up, especially if a patient is over GI bleeding. So the performance during the time is very important for picking up these tests. The video capsule, there's several of the video capsules available in the market. I won't go too much into detail of this, but this is a simple, easy test as a first-line test. And then you could follow this by device-assisted, balloon-assisted enteroscopy, and commonly what we use is a single or a double balloon enteroscopy. This is one of how the balloon works. It has a good diagnostic yield and a good therapeutic yield for a double balloon. But only few centers have this, so it's important to know when to send a patient or refer a patient for enteroscopy. The other modalities, and briefly let me touch one or two parts of each pair. The CTA or CT angiography, very good tool in an unstable patient. It is usually useful for tumors or localizing lesions like that, but it will give you a roadmap for the intervention radiologist to tell you where to go and target the lesion. A nuclear scan has very low yield. It just tells you whether there is some bleeding source or not. It doesn't tell you exactly where it is. But a Meckel scan is much more useful in that situation. And all these can be followed up with intervention and angiography, which is very helpful in unstable patient to treat and embolize the lesion. These are some examples of enteroscopy where we have seen bleeders. This is actually one of our patients with Meckel's diverticulum. This is a patient with Hawes and angiodysplasia, or neuroendocrine tumors are some of the examples of. The most common lesion that you find in small bowel bleeders are usually vascular lesions. So angiotases are the most commonest things. And the risk factors are aortic stenosis, chronic renal failure, LVAD. We used to see a lot of patients who come with heart failure and LVAD devices. Fortunately, this is coming down because they're using much new generation LVADs and the bleeding source is much less. There you can use hemostatic therapy. For example, you can use thermal therapy with argon plasma coagulation. And this is all examples of thermal therapy. Mechanical therapy is using these clips. These are using hemostatic clips. Actually, this is a patient with a gastric intestinal stromal tumor, which was bleeding, and that's the histology and the surgical specimen. You can actually tattoo these areas. In altered anatomy, for example, this is a patient who had bypass and was bleeding actively. We had inject and further place clips to take care of the bleeding. So alternate anatomy is another area where a pill cam doesn't help you, difficult to reach areas where a double balloon helps you. There are some new therapies like sprays and powders that you can use as topical agents, and these agents are very helpful to temporizing bleed. This is an example of an ulcer that was bleeding in the second part of duodenum, and we applied this topical agent and was able to temporize it. So there are new studies that are coming out can show that it can be used as a bridge to a definitive therapy. It can buy you time, but also it could be used also as a first-line therapy. There are various agents that are out in the market right now. So newer studies or data are coming out, randomized, which show that it could be even used as a first-line therapy also. This is another device, which is the bear claw, what an over-the-scope clip is useful in certain lesions which are refractory to bleeding. There are some meta-analyses which show that over-the-scope clips helps as a first-line therapy also. And it can be used by any physician who is trained in doing this. It has a good compression and able to take care of refractory bleeding lesions. So lastly, a few things. This is something Shyam does a lot for variceal bleeding. They use an EUS and they can inject glue inside it and take care. You see a big fundal varices in the picture A, and this can be injected with coils or glues. And so these are gastric varices that can be very difficult to manage. Another area that you might consider are patients who had interventions and they come back with a bleed. They'll come to the ED. I had a colonoscopy a couple of days back. and now I have a bleeding, and they took out a polyp, and many times you can see a resected polyp which is bleeding. And so you can do hemostatic treatment for those patients, admit them, monitor them, and therapy on these kind of patients. Anticoagulation management, briefly on this, you can reverse with vitamin K antagonist and I think the important thing is that temporarily stopping it and restarting it based on what the cardiac risk is very important. So this is a risk stratification you have to do with the cardiac team to see what is the benefit of stopping the anticoagulation and when to restart it. So I'm not going to go too detailed into this, but you need to understand the patient is on anticoagulation, stop it briefly, and then decide when to start it based on the risk of the patient. Finally, the few take-home points. It's important for early resuscitation and supportive care to reducing mortality and morbidity from GI bleeding. Risk scoring, as we talked about, appropriate timing, when to admit a patient, and the timing for endoscopy. What you see on endoscopy will prognosticate whether the patient will stay in the hospital or go, or how long he needs to be there, and what kind of therapy you're going to offer. And the risk anticoagulation, as I mentioned in the previous slide, was it's not dying is better than not rebleeding. So you can manage a rebleeding, but because of a cardiac event, you don't want that happening when a patient is. And also then, what are the different modalities and how do you define it? Upper, lower, mid bowel, and how do you use each kind of therapy to diagnose and manage these patients? It's like a volcano, you know, you never know when it's erupting, you know, it might be just there, a little smoke, but that's when you need to catch it. That's where your brain has to see as the patient comes into the triage room or into the ED when you assess him. Thank you.
So is there any questions for Dr. Peter? So at least I can tell you that in our unit, we have not sent a patient for surgery for bleeding so far in the last 3 years. GI bleeding should be stopped by endoscopy. There is no role for surgery, particularly if it is an ulcer bleed and so on. You should be able to stop it. That is one. Second, if you are an endoscopist, it doesn't mean that you're good in GI bleeding. In our own unit, we have a doctor who specifically does double balloon because he's dedicated, persistent. And we've got a couple of people like Dr. Bang and Dr. Hawes who will not quit. They enjoy bleeding. And if it is an hour and a half, they will stay an hour and a half. They will stop the bleeding. I have seen patients on the way to hospice who are stopped, who landed, who then walked back home. So there are multiple devices, and it's because people who do resections, ESD and EMR, clip closures, quab graspers, there are multiple tools. They are the best people to manage GI bleeding. So GI bleeding should not go for surgery anymore. So thank you so much. And we're going to go to the last topic. Thanks, Shajan. I'm going to have Arvind Murali talk about liver. Arvind runs the liver unit. So Orlando Health did not have liver. Now he sees about 400 patients a month. He has a very busy liver service with about 15 patients. He's considered the best teaching attending in the health system. He's hired a second hepatologist, on his way to hire a third and establish a liver transplant program all by himself. My only disappointment with him was that he went, instead of practicing endoscopy, he took the wrong organ. But he'll be forgiven. So he's going to give this talk, and then within 2-3 minutes, he's going to talk all about liver. And then you can go to the back and grab some snacks. And he's going to give a liver topic, but there'll be wine served. So that's all right. Nothing happens. Thank you, Arvind.
Thank you. I chose liver because I don't enjoy blood. And I love the physiology of liver. So I enjoy liver. I like to manage liver patients. I'm happy to be here to give this talk. So we're going to start with the objectives for this talk. Isolated elevation of total bilirubin, to discuss a useful way of characterizing liver test abnormalities. Learn the tests needed to confirm diagnosis of common liver disorders, and discuss management of specific liver diseases. We'll start with a few questions. We'll have a poll, but we will revisit these questions at the end of the talk, and we will do another poll at that time. So the question one is 35-year-old male with jaundice. He recently recovered from influenza. History of binge drinking on the weekends. Total bilirubin is 4.3. Direct bilirubin is 0.4. Alkaline phosphatase is 104. AST is 28. ALT 16. Hemoglobin 13.6. Platelet count 182. What is the most likely diagnosis? Acute viral hepatitis, hemolysis, Gilbert syndrome, Wilson disease, and acute alcoholic hepatitis.
Okay.
Good. A second question. Which of the following liver values help predict mortality in patients with alcohol-associated hepatitis? Total bilirubin, AST, ALT, alkaline phosphatase, and GGT.
Let's run it.
Okay. Question 3. 45-year-old male referred for evaluation for abnormal test results for hepatitis B obtained prior to initiation of rituximab containing chemotherapy. Hepatitis B surface antigen is negative. Hepatitis B surface antibody is positive. Hepatitis B core antibody total is positive. What is the most likely diagnosis and treatment plan? Acute hepatitis B, start antiviral therapy. Chronic hepatitis B, start antiviral therapy. Immune by vaccination, no therapy needed. Natural immunity to hepatitis B, no therapy needed. Natural immunity to hepatitis B, start antiviral therapy.
Let's.
Okay. Last question. What percent of adult patients develop chronic hepatitis C after an acute hepatitis C infection? 30%, 50%, 70%, and 90%.
Okay.
Okay, very good. So we have the answers for all these four. Hopefully at the end of this talk, we'll have 90% or more for all the questions, right, on the right answer. Let's look at bilirubin fractions. So the total bilirubin is a combination of conjugated and unconjugated. So in other words, it's a combination of direct bilirubin and indirect bilirubin. So when you order a hepatic panel, many laboratories, they only report the total bilirubin level. An isolated elevation of bilirubin, whenever you see an isolated elevation of bilirubin with all the liver enzymes being normal, always measure the direct bilirubin. The direct bilirubin in healthy subjects should be less than 10% of total bilirubin. So the direct bilirubin should be less than 10% of total bilirubin. When you see an elevation in direct bilirubin or the conjugated bilirubin, it always indicates liver disease. Presence of bilirubin in urine always implies liver disease. This is because only the conjugated bilirubin appears in urine. The unconjugated bilirubin or the indirect bilirubin is albumin bound and water insoluble. So when you have indirect bilirubin, and if it is more than 90% of the total bilirubin, liver disease is never the explanation. Instead, you think of either hemolysis or Gilbert syndrome. So when the indirect bilirubin is more than 90%, then it's either hemolysis or Gilbert syndrome. If the hemoglobin is low, then you suspect hemolysis. If the hemoglobin is normal, then you think of Gilbert syndrome. And this is an inherited disease. It is a decrease in the inability to conjugate bilirubin. So it is an inherited disease, and there is an inability to conjugate bilirubin. It is seen in about 5% of general population, usually diagnosed in the young and in healthy individuals. It causes mild hyperbilirubinemia without any symptoms. Fasting, dehydration, exercise, and intercurrent illnesses such as influenza, they often cause an increase in bilirubin level in Gilbert syndrome. Again, 90% or more of the total bilirubin is unconjugated or indirect. There is no evidence of hemolysis. All the liver enzymes, AST, ALT, and alkaline phosphatase will be normal. And when you see this pattern, there is no need for an imaging study or a liver biopsy, because this is not associated with liver injury or chronic liver disease. So you reassure the patient, tell the patient he has Gilbert syndrome, and you can discharge this patient from your clinic. So when you evaluate elevation in liver enzymes, it is always useful to categorize into 3 patterns of liver injury. Hepatocellular pattern, where the primary injury is to the hepatocytes. Cholestatic pattern, where the primary injury is to the bile ducts. And infiltrative pattern, where the liver is invaded or replaced by non-hepatic substances, usually things like lymphoma or amyloidosis. So when you make this pattern distinction between hepatocellular or cholestatic, you have to use alkaline phosphatase and AST ALT to make this distinction. Bilirubin is not used for pattern recognition. Elevation in bilirubin does not imply cholestatic. If your AST and ALT are significantly higher than alkaline phosphatase, this is hepatocellular pattern. When the alkaline phosphatase is significantly higher than AST or ALT, it is cholestatic pattern. In infiltrative pattern, there is elevation of alkaline phosphatase with the near normal AST and ALT. But for infiltrative pattern, many times you will need a biopsy to diagnose. Most important thing is do not use bilirubin for pattern recognition. Bilirubin can be elevated in acute viral hepatitis, in acute autoimmune hepatitis, which are all hepatocellular pattern, and it can be elevated in cholestatic conditions like bile duct obstruction, PBC, or PSC. So the most common causes for hepatocellular pattern of liver injury is MASLD, alcohol-associated liver disease, drug-induced liver injury, chronic hepatitis B or C infection, autoimmune hepatitis, hemochromatosis, Wilson disease, or alpha-1 antitrypsin deficiency associated liver disease, and celiac disease. Always remember celiac disease in clinic when you're seeing patients with elevation in liver enzymes. You think of celiac disease, evaluate for celiac disease. Almost every month we see 1 or 2 patients who are diagnosed with celiac disease because of elevation in liver enzymes. Cholestatic pattern, the most common causes are bile duct obstruction, PSC, PBC, and again, drug-induced liver injury. So always think of drug-induced liver injury no matter what the pattern of elevation of liver enzymes are. Some drugs cause hepatocellular pattern, some drugs cause cholestatic pattern of liver injury. The most common causes for infiltrative pattern are amyloidosis, sarcoidosis, and infiltrative HCC, lymphoma. This infiltrative pattern often overlaps with cholestatic pattern, so almost always you will need a liver biopsy to help differentiate or to diagnose infiltrative pattern. So we'll move on to determination of specific liver disorders. So acute alcoholic hepatitis. So acute alcoholic hepatitis, as you know, may be either mild or can be life-threatening. The main clue is that the AST is higher than the ALT, and the ratio is greater than 2:1 in more than 70% of patients. If the ratio is more than 3, it is strongly indicative of alcoholic hepatitis. Elevation of GGT further supports alcoholic liver disease. Now, this is really important in alcohol-associated hepatitis, that the AST is usually only in the 100 to 200 range, even in severe disease. The ALT level may be mildly elevated or even normal. So when you see an AST that's more than 500, or when you see an ALT that's more than 200, it is important to understand that this is not explained by alcoholic hepatitis alone, and the patient may either have a second etiology in addition to alcoholic hepatitis or an alternate etiology. So no matter how severe the alcoholic hepatitis is, your AST is unlikely to be more than 500 and the ALT is unlikely to be more than 200. So always look for alternate etiologies. So the question on mortality in alcoholic hepatitis and AST and ALT levels, they do not predict mortality, neither the alkaline phosphatase. So to predict mortality in alcoholic hepatitis, we have to use total bilirubin and prothrombin level, or the PT. So you all might have heard of the Medrese discriminant function. So the Medrese discriminant function is what you have to calculate to determine severity of alcoholic hepatitis. And Medrese discriminant function uses prothrombin time and total bilirubin. So prothrombin time and total bilirubin are the predictors of mortality in alcoholic hepatitis. When your Medrese discriminant function is more than 32, these patients have severe alcoholic hepatitis. They have a 30 to 50% 1-month mortality. So that is why any patient with alcoholic hepatitis, please calculate the Medrese discriminant function. It involves prothrombin time and total bilirubin. So let's look at an algorithm for managing alcoholic hepatitis. So the first step is to assess eligibility for treatment. So we discussed the MDF more than or equal to 32. Similarly, if the MELD score is more than 20, you can also consider the patient for treatment. You obtain abdominal ultrasound to exclude other causes of jaundice. The most important before initiating treatment in alcoholic hepatitis is to screen for infections. You always do chest X-ray, blood cultures, urine analysis and urine cultures. And if the patient has ascites, please try to do a paracentesis to rule out spontaneous bacterial peritonitis. The most common cause of mortality in alcoholic hepatitis is infection. So you have to screen for infections before treatment. You look for contraindications to treatment, which is uncontrolled infection, acute kidney injury with creatinine that is more than 2.5, uncontrolled upper GI bleed, and if you have concomitant diseases including active hepatitis B, active hepatitis C, or hepatocellular carcinoma, acute pancreatitis, or if the patient has multi-organ failure or shock. So once you have evaluated the patient for eligibility and you have ruled out contraindications, then you start the patient on prednisolone. Prednisolone, 40 milligram daily. If the pharmacy does not have prednisolone, then you can certainly use prednisone, but the first line would be prednisolone. In some patients with severe alcoholic hepatitis, I also use IV NAC. Prednisolone plus IV NAC has shown in some studies to be beneficial. But prednisolone 40 milligram PO daily is the primary treatment for alcoholic hepatitis. And the second and crucial aspect of treatment of alcoholic hepatitis is nutrition. Involve your dietitian, make sure the patient has good nutrition, high protein diet at 1.2 to 1.5 gram per kilogram per day, and nutrition has shown to improve survival in patients with alcoholic hepatitis. Now, the next question would be, once you start somebody on prednisolone, what do you do? How long do you use the prednisolone? Historically, we used to use prednisolone for 28 days, but now we have very good data to suggest that there are some patients who would benefit from prednisolone, but there are some who have no response to prednisolone. And if you use prednisolone for patients who do not have a response, you're only increasing the risk of infections. So that is why we have the LIL model, and this score you calculate at day 7 of prednisolone. When you calculate the LIL score at day 7 of prednisolone, if you see that the LIL score is less than 0.45, this means that the patient is responding to treatment with prednisolone. And when the patient is responding to treatment with prednisolone, you continue it for 28 days, and this is extremely important. If the LIL score is greater than 0.45 and you don't see any improvement in their bilirubin, they come in at 15, you put them on 5 days of prednisolone, their bilirubin is 14, 15, the LIL score is greater than 0.45, then you have to discontinue prednisolone. They are not benefiting from prednisolone. So always remember the LIL score when you start a patient on prednisolone. Another important quality indicator is before this patient is getting discharged from the hospital, involve the mental health therapist or a social worker to provide information to patient regarding alcohol relapse prevention and recommend inpatient or outpatient rehab to these patients. Now, if this patient is ineligible for treatment to prednisolone, or if the patient is not responding to prednisolone, then you consider evaluation for liver transplantation. And I want to stress one thing here. Previously, we used to have the 6-month abstinence rule before being considered for transplant. That is no longer the case. There are some patients that we select based on specific criteria, and we can offer early transplantation for these patients. And there are criteria that the transplant centers use based on their history of alcohol use, based on the number of episodes of alcoholic hepatitis that they have had, and the social support that they have. So if a patient has acute alcoholic hepatitis, severe acute alcoholic hepatitis, not responding to prednisolone, please consider talking to a transplant center. So again, alcohol use disorder, this is an important aspect of treating patients with alcoholic hepatitis. So patients with alcoholic liver disease or other liver diseases, in particular MASLD or viral hepatitis, should be counseled that there is no safe level of drinking and they should abstain. So many times we have patients with fatty liver disease in clinic asking how much of alcohol they can drink, and at this point there is no safe level of drinking. We recommend complete abstinence. And if a patient has alcohol use disorder, please refer them to treatment professionals. Studies have clearly shown that those who undergo treatment have a lower risk of relapse. The use of acamprosate or naltrexone, sometimes even baclofen, can be considered. In our clinic. We try to use either acamprosate or naltrexone based on the degree of liver dysfunction. Moving on to MASLD, formerly called non-alcoholic fatty liver disease. So as everyone knows, is the most common cause of mildly elevated liver enzymes. The ALT is higher than the AST. And it is defined as accumulation of fat in the liver in the setting of metabolic dysfunction, which is elevated BMI, diabetes mellitus, or dyslipidemia. And in the absence of conditions that cause secondary fat accumulation, which is significant alcohol use, or certain medications that can cause hepatic steatosis, genetic conditions, or viral hepatitis. So patients with hepatitis B and C can have fat infiltration in the liver. And I think this is one of the most important slides that I want to put out. This is how do you care for or manage a patient with MASLD that comes to your clinic, right? Because we have a lot of patients with MASLD and it's not possible to see all these patients in the clinic. So you have to have a risk stratification to determine who needs treatment, who needs follow-up, and who can be followed by primary care physician. And if you look at the primary care, many times we recommend primary care physicians to calculate FIB-4 index. And this is a very simple score, uses a platelet count, age, AST, and ALT. When this FIB-4 index is less than 1.3, it has a more than 95% predictive value for low fibrosis score in patients with MASLD. So when the FIB-4 index is less than 1.3, these patients can follow up with their primary care physician. They need to reassess the FIB-4 index every 1 to 2 years, especially if they have metabolic risk factors. But when the FIB-4 index is more than 1.3, these are the patients who need further assessment. So when the FIB-4 is more than 1.3, you consider either a VCTE or a fibroscan if you have in clinic, or an elastography or ultrasound elastography, or you can use other blood-based tests like the ELF score. So let's say you have a fibroscan, since most clinics have fibroscan. If your fibroscan shows that the patient has F0 or F1, then these patients can be followed up in 2 years. Whereas if your fibroscan is showing F2 or above, then these are the patients who should be considered for treatment and monitoring. And these are the patients who should be followed in the GI clinic or in the liver clinic. So if you look at this algorithm under secondary risk assessment, so if the risk level is low is when the VCTE is less than 8, risk level is intermediate when the VCTE is 8 to 12, and the risk level is high when the VCTE score is greater than 12. Now the one question that arises with having fibroscans is, do we need to biopsy these patients? Biopsy still has a role in patients with MASLD, but the most important reason to biopsy is if there is a diagnostic uncertainty. If the patient has very high liver enzymes, AST, ALT, 200s, 300s, or if they have autoimmune markers that are positive, it is extremely important to rule out autoimmune hepatitis. So liver biopsy, there is still a role for liver biopsy despite the presence of fibroscans and MRE, especially in the setting of diagnostic uncertainty. Another indication for biopsy would be if you have discordant results. You see someone in clinic, BMI is around 42, FibroScan says F4 fibrosis, but you see all their other clinical parameters are completely normal. So you have to try to work this patient further before calling them cirrhosis. You can either consider an MR elastography as a next modality, or you can do a liver biopsy. So in case of diagnostic uncertainty or if there is discordant results, then you can consider a liver biopsy. So if you look at the bias staging, if they are stage 0 or 1, you reassess in 2 to 3 years. If they are stage 2 or stage 3, you reassess annually and consider pharmacotherapy. If they are stage 4, which is cirrhosis, then you manage as per recommendations for cirrhosis, which would be HCC surveillance and variceal screening. So moving on to viral hepatitis. So hepatitis A is straightforward. It is an acute self-limited illness. There is no chronic hepatitis A. There are only 2 tests to perform for hepatitis A, which is a hepatitis A IgM and hepatitis A total antibody test. If you're suspecting acute hepatitis A, you order hepatitis A IgM. If your IgM is positive, you can confirm the patient has acute hepatitis A. If you want to check to see whether somebody needs a vaccination, then you check hepatitis A total. And if your hepatitis A total antibody test is positive, then this patient is immune. He does not need vaccination. So tests for hepatitis B, and hepatitis B is more complex than hepatitis A, and we will try to go over this slow. So the four main tests are hepatitis B surface antigen, hepatitis B surface antibody, hepatitis B core total antibody. So core total antibody measures both IgG and IgM. And then you have hepatitis B core IgM. So just like in hepatitis A, when your IgM is positive, you have acute hepatitis B. When your IgM is positive, it is acute hepatitis B. When your core total is positive, it means you have had an infection to hepatitis B in the past. When your core total is positive, it means at some point you have had an infection to hepatitis B. Core total is only positive if you have had an infection to hepatitis B. And if these two important aspects are remembered, the rest becomes easy. So let's look at acute hepatitis B. So acute hepatitis B, your hepatitis B surface antigen is positive, and your IgM, core IgM is positive. So when you have hepatitis B surface antigen and core IgM positive, you can make a diagnosis of acute hepatitis B. For chronic hepatitis B, the definition is that you need to have surface antigen that is positive for more than 6 months. Core total antibody will be positive, but your IgM will be negative. When your core total antibody is positive and IgM is negative, then you know this is chronic hepatitis B. So, and this is again extremely important, especially as gastroenterologists and hepatologists, we need to know the distinction between these three. The first is straightforward. This is a patient who is susceptible to infection because their surface antigen is negative, core is negative, surface antibody is negative. So this patient has never been infected and has never received any vaccination. The next two is where the surface antigen is negative, but their core total is positive and their surface antibody is positive. So because their core total is positive, this patient has been infected in the past, and this is extremely important. Now the surface antigen is negative, so this patient does not have chronic hepatitis B. The surface antigen is negative, does not have chronic hepatitis B. The patient had hepatitis B before, has cleared the virus. So right now, the surface antigen is negative, so it is not chronic hepatitis B. The core antibody is positive, so this patient is immune because of prior infection or immune due to natural infection. When you look at the last set, the surface antigen is negative, the core is negative, and only the surface antibody is positive. So when the core is negative and the surface antibody is positive, this patient has received vaccination. This is a patient who cannot get hepatitis B. This is a patient we don't have to worry about. So the important distinction is between the immunity from natural infection and immunity due to hepatitis B vaccination. And the distinction is based on core antibody total. Core antibody total indicates past infection, and this is extremely important to check and extremely important to know. And the reason for that is because of reactivation of hepatitis B. Reactivation of hepatitis B is where a patient who currently does not have hepatitis B infection but had it at some time in the past, and now the patient receives chemotherapy. They receive rituximab because they have lymphoma. And when their immune system is suppressed, the hepatitis B is a DNA virus. So it is always there in the patient's liver. And when their immune system is suppressed, the hepatitis B flares up. The surface antigen will turn positive. Patients develop acute liver injury, and about 2 to 5% of these patients can even develop acute liver failure. So whenever a patient is referred to you before starting any immunotherapy, or if you're in the IBD clinic and you want to start somebody on infliximab, biologics, you have to check for hepatitis B core antibody total. And this is one of the most common things that is missed before someone is started on chemotherapy or immunotherapy. So please check hepatitis B core antibody total. Now, what do we do when we see this? So if someone is sent to me because they want to start the patient on rituximab and they have immunity due to natural infection, which is core antibody total positive, these patients have up to a 5 to 10% risk of reactivation, so you have to start them on antiviral therapy. So antiviral therapy is initiated before the patient is started on rituximab in patients who are immune due to natural infection. For other chemotherapies, even if they're not on rituximab, other chemotherapies, the risk is slightly lower, but I would strongly encourage starting them on treatment. And the treatment will be continued up to 12 months after the last dose of rituximab, or up to 6 months after the last dose of other chemotherapy. Because a hepatitis B can reactivate even after the treatment is stopped because it takes time for the immune system to recover. So if someone has immunity from natural infection to hepatitis B and they're going to be started on chemotherapy, especially rituximab, start them on antiviral prophylaxis. Last topic is hepatitis C. So 30% of adults who get acute hepatitis B will clear the virus. So actually, the majority of patients who develop acute hepatitis C will develop chronic hepatitis C. So 70% of patients who develop an acute hepatitis C infection will develop chronic hepatitis C. Tests for to detect hepatitis C, the hepatitis C antibody test is the most common, and then you have the hepatitis C viral load. You look at the algorithm to diagnose hepatitis C. If you're suspecting acute hepatitis C, then do not order the antibody. Antibodies may not be positive in acute hepatitis C. If you're suspecting acute hepatitis C, order the viral load. If you're suspecting chronic hepatitis C, there's a patient in clinic who's got very mild elevation in liver enzymes, then you order the antibody test. You don't need to jump to a viral load. Only in the case of immunosuppressed patients or HIV patients, you will need a viral load. If not, antibody test is good enough. If the antibody test is positive, then you order the viral load. If the viral load is positive, then you confirm this patient has chronic hepatitis C infection. But if the viral load is negative, even if the antibody is positive, if the viral load is negative, this patient does not have chronic hepatitis C. And this is something you're bound to encounter a lot these days because we have treated so many hepatitis C, and primary care physicians may refer a patient to you because their antibody is positive. But when you do the viral load, if the viral load is negative, this patient does not have chronic hepatitis C. You probably had it in the past. He might be in the 30% of patients who spontaneously cleared it, or he might be someone who was treated before. So if your viral load is negative, then this patient does not have chronic hepatitis C. If they have positive, if they have chronic hepatitis C, all patients with chronic hepatitis C should be treated. We have really good treatments, good cure rates. We can decrease the risk of decompensated cirrhosis, decrease the risk of HCC by curing hepatitis C. Okay, so we will move on to the questions. So there's a 35-year-old male, presents with jaundice, recently recovered from influenza. Total bilirubin is 4.3, direct bilirubin is 0.4. Rest of the liver enzymes are normal, hemoglobin is normal. What is the most likely diagnosis? Okay, we have 75% for Gilbert syndrome. So it is, as you can see in the question, this is clearly indirect hyperbilirubinemia. So the direct bilirubin is less than 10% of the total bilirubin. Patient does not have anemia. So this is not, and all the other liver enzymes are normal. So this is not liver injury. This is Gilbert syndrome. Move on to the next question. Which of the following liver values help predict mortality in patients with alcohol-associated hepatitis? Total bilirubin, AST, ALT, alkaline phosphatase, and GGT. Okay, that's fantastic. Yes, total bilirubin. Total bilirubin and prothrombin time are the two main predictors of mortality. Total bilirubin and prothrombin time. Okay, so 45-year-old male has hepatitis B surface antigen is negative, but surface antibody is positive and core antibody total is positive. This patient is going to be started on rituximab. So what is your diagnosis and treatment plan? Okay, at least we moved from 10% to 52%, so I'm happy. This is natural immunity to hepatitis B because this patient has core antibody total positive, which means past infection to hepatitis B. So this is natural immunity. It is not chronic hepatitis B because the surface antigen is negative. And this patient is going to be started on rituximab, so we need to start antiviral therapy. Natural immunity to hepatitis B and start antiviral therapy. Okay, last question. What % of adult patients develop chronic hepatitis C after an acute hepatitis C infection? 70% is correct. 70% is correct. Fantastic. Thank you very much.
So, any questions for Dr. Murali? So we have snacks at the back, and then if you want to grab a drink, you can. In 2 or 3 minutes, I think Dr. Murali is going to talk about non-cirrhotic liver disease in the setting of fatty liver. It'll be a 20-minute talk. So let's start right away so that we can be done on time. Thank you. So we're going to get started with this program. I'm not going to rush you. Please get your snacks and your drink and come join us. Tomorrow morning, we will start sharp at 7:55 for the main session. And then tomorrow evening at 6 o'clock, we have a reception as well. So just make sure you join us for the reception tomorrow evening at 6. So we're going to get started with this event. Kim, please do the introduction. All right, let's go.
Okay, thank you. Okay, so this talk is basically regarding the new treatment for MASLD, Resmetirom. So Resmetirom in conjunction with diet and exercise is the first and only FDA-approved treatment for adults with non-cirrhotic NASH with moderate to advanced fibrosis. So this indication is approved under accelerated approval. This is based on improvement of NASH and fibrosis. And continued approval for this indication may be contingent upon verification and description of clinical benefit in confirmatory trials. The disclosures regarding this program is this promotional educational activity is not accredited, and the program content is developed by Madrigal Pharmaceuticals and may not be distributed. The consultant is a paid speaker for Madrigal Pharmaceuticals. So what are we going to be discussing today is the unmet need and patient identification. What is the mechanism of action of Resmetirom? The dual primary efficacy results, which is resolution of NASH and fibrosis improvement. We're going to be talking about the safety profile, dosing and getting patients started, and key highlights. So as we all know, patients with NASH or MASLD with moderate to advanced liver fibrosis, they require prompt identification and therapeutic management due to the risk of disease progression. Why should we identify patients with moderate or advanced fibrosis? Because it is the most important predictor of risk. So we know that patients with fibrosis stage F2 or F3 are at a higher risk of developing major liver events or hepatic decompensation. And the rate of progression is unpredictable because this rate of progression, it varies from patient to patient depending on comorbid conditions, their genetic profile, environmental factors, and disease severity. So if there is a patient with MASLD who drinks alcohol versus a patient with MASLD who does not drink alcohol, that can influence the rate of progression. And we all know that the prevalence of MASLD or NASH is increasing. So patients with NASH F2 and F3 is increasing in prevalence, yet many of these patients remain undiagnosed. And we have many patients in clinic that we first see after they have hepatic decompensation or after they develop hepatocellular carcinoma. So the goal is to try to identify these patients when they have F2 or F3 fibrosis to try to delay or avoid the progression to cirrhosis and decompensation. So we all know that patients at high risk for NASH, they often have other comorbidities. If you look at the prevalence of multiple comorbid conditions associated with NASH, 82% have obesity, 48% have type 2 diabetes, 82% have dyslipidemia, and 70% have hypertension. So the AASLD, the AGA, as well as the AACE, which is the American Association of Clinical Endocrinology, all these guidances, they recommend sequential risk assessment with non-invasive tests to identify adult patients with NASH with moderate to advanced liver fibrosis. So very similar to the algorithm that we previously learned, the first step is to identify high-risk patients, identify patients who have moderate or advanced fibrosis. Usually these are the patients who have either diabetes or obesity, they have 2 or more metabolic risk factors, they have steatosis on imaging, They may have elevated liver enzymes, and extremely important to rule out other causes for fibrotic liver diseases, especially autoimmune liver disease. And then you do the primary risk assessment, ideally done at the primary care physician's office, but many times we do it in the GI or the liver clinic. If the FIB4 is less than 1.3, low risk. If the FIB4 is more than 1.3, then these patients need further assessment. And the secondary risk assessment is the VCTE or the FibroScan or ultrasound elastography. When the VCTE is less than 8, these patients are at low risk. So in our liver clinic, when a patient comes to our clinic, we do a FIB4 and we do a FibroScan at the same time. Same day, same time. If the FIB4 is less than 1.3, if the VCTE is less than 8, then we recommend either follow up with the primary care physician, or if they want to come back, we can reassess them in about 2 to 3 years. So if the FIB4 is low and the VCTE is low, these patients are at low risk. However, if the FIB4 is more than 1.3, then you do a FibroScan. If the FibroScan if the Fibro score is more than 8, then these patients have moderate or advanced fibrosis. And these are the patients who will need active management and monitoring. So moving on to regarding Resmetirom. So as we discussed, it is indicated in conjunction with diet and exercise. So never forget diet and exercise. It is still the first line treatment, extremely important to let patients know that just because we are prescribing a medication, they cannot forget about diet or exercise. Weight loss is extremely important. So Resmetirom is indicated in conjunction with diet and exercise for the treatment of adults with non-cirrhotic NASH with moderate to advanced fibrosis, or stages F2 to F3 fibrosis. And it is approved under accelerated approval based on improvement of NASH and fibrosis. And for continued approval is contingent upon verification and description of clinical benefit in confirmatory trials. The most important, do not use or avoid use in patients with decompensated cirrhosis. It is not meant for patients with decompensated cirrhosis. And what is some of the important safety information? Hepatotoxicity. So hepatotoxicity has been observed with use of Resmetirom. There was one patient in the trial who had normal ALT, AST, and total bilirubin at baseline, received Resmetirom 80 milligrams, and developed substantial elevations of liver biochemistries that resolved when the treatment was interrupted. When they reinitiated Resmetirom, there was significant elevation in AST, ALT, and total bilirubin. The peak value were 58 times the upper limit of normal for ALT, 66 times the upper limit of normal for AST, and 15 times the upper limit of normal for total bilirubin with no elevation of ALP. And these enzymes and liver enzymes were accompanied by elevation in immunoglobulin G level, suggesting a drug-induced autoimmune-like hepatitis. The liver tests returned to baseline following hospitalization and discontinuation of Resmetirom without any therapeutic intervention. So it is important to monitor patients during treatment with Resmetirom for elevations in liver tests and for the development of liver-related adverse reactions. Monitor for any signs or symptoms, and if you suspect hepatotoxicity, you discontinue the medication and monitor the patient. If the laboratory results do not return to baseline, then consider drug-induced autoimmune liver disease in the evaluation of elevation in liver tests. If you look at the most recent AASLD recommendations, it is important to monitor liver enzymes at 3 months and 6 months after starting Resmetirom. Gallbladder-related adverse reactions in clinical trials, cholelithiasis, acute cholecystitis, and obstructive pancreatitis were observed more often in Resmetirom-treated patients than in placebo-treated patients. If you suspect cholelithiasis, then gallbladder diagnostic studies and appropriate clinical follow-up are indicated. And if you suspect an acute gallbladder event, then interrupt treatment until the event is resolved. And there is some drug interaction with certain statins, and there is a dosage adjustment, and which we will discuss in the future slides. But if the patient is on statin, you need to monitor for statin-related adverse reactions, which includes elevation in liver tests, myopathy, and rhabdomyolysis. So mechanism of action. So what is the mechanism of action of Resmetirom? So it is a first-in-class thyroid hormone receptor beta agonist that works directly in the liver. So there is thyroid hormone receptor alpha and thyroid hormone receptor beta. And Resmetirom is a partial agonist of thyroid hormone receptor beta, and this is the major form of thyroid hormone receptor in the liver. And stimulation of this receptor, it decreases intrahepatic triglycerides. Whereas the actions of the thyroid hormone outside the liver, including the heart and the bones, they are mediated through thyroid hormone receptor alpha. So by reducing intrahepatic triglycerides, resmetirom, it decreases liver fat content as measured by MRI-PDFF, which is a proton density fat fraction that is calculated on the MRI, or the CAP score on the fibroscan, which is a controlled attenuation parameter that we check on the fibroscan. Reductions in liver fat content by MRI-PDFF were observed at 16 weeks, which was the first assessment, and at 52 weeks of treatment. And reductions in liver fat content by CAP were observed at 52 weeks of treatment. So the important question is the Resmetirom, it produced 83.8% of the maximum response compared to T3. And this was an in vitro functional assay for thyroid hormone receptor beta activation. So let's look at the Maestro-NASH clinical trial design. So the efficacy and safety of resmetirom were evaluated in this Maestro-NASH trial. It had 888 patients. It is an ongoing phase 3 randomized double-blind placebo-controlled trial. Both the efficacy and safety was evaluated in 888 adults with biopsy-confirmed NASH with liver fibrosis stages F2 and F3. 294 patients received placebo, 298 patients received 80 milligrams of Resmetirom, and 296 patients received 100 milligrams of Resmetirom. If you look at the endpoint, it was a dual primary endpoint at week 52. So what is a dual primary endpoint? It included NASH resolution and fibrosis improvement. NASH resolution was defined as a resolution of steatohepatitis without worsening of liver fibrosis. And fibrosis improvement was greater than or equal to 1 stage improvement in fibrosis without worsening of steatohepatitis. And liver fibrosis was evaluated on the NASH Clinical Research Network fibrosis score as 0 to 4. So what is the key inclusion criteria? Presence of metabolic risk factors. The NAFLD activity score, which is based on the biopsy, which we will talk in the upcoming slide. The NAFLD activity score should be greater than or equal to 4, and these patients should have a fibrosis stage F2 or F3. The key exclusion criteria was moderate to severe hepatic impairment or Child-Pugh B or C, patients who had cirrhosis, and liver decompensation. So what is this NAFLD activity score? So NAFLD activity score is a composite score of histologic observations. This is used for assessment of disease severity and for NASH diagnosis. So the NAFLD activity score can range from 0 to 8, and it is calculated by summing the scores for key histologic features. So what are the key histologic features in NASH? It is steatosis, lobular inflammation, and hepatocyte ballooning. So we get a max of 3 points for steatosis, a maximum of 3 points for lobular inflammation, and you need to have, you can get a maximum of 2 points for hepatocyte ballooning, so that makes it a total of 8. So in the study, the patients needed to have 4 or more to be included in the study. And the fibrosis stage based on the NASH CRN scoring system. So stage 1 is where they have early perisinusoidal fibrosis with delicate collagen strands between ballooned hepatocytes. Stage 2 is where they have advanced perisinusoidal fibrosis. If you look at the blue, that is the stain, Mason stain, and you can see the scar tissue. And stage 3, you can see that the fibrosis is bridging, and there is an extensive network of fibrosis in stage 3. And stage 4, you can clearly see a nodule that is completely surrounded by fibrosis. So this is stage 4 or established cirrhosis. So for the clinical trial, patients with stage 2 and stage 3 were included. Let's look at the baseline patient characteristics. The median age was 58, 56% females, 21% Hispanics, 89% were white. The median BMI was 35. Median body weight was 99. Type 2 diabetes was seen in 68% of patients, hypertension in 79, dyslipidemia in 71. 49% of these patients were on statins, and 14% of these patients were on thyroxine. And patients during the study were on stable doses of medications for diabetes, dyslipidemia, and hypertension. And if you look at the baseline characteristics on liver biopsy, about 37% at F2, 63% at F3. Their median VCTE, which is the score on the fibroscan, was 12. The CAP score median was 349. The median FIB4 was 1.3, and the median ELF score was 9.7. And patients in the study had a NAFLD activity score of greater than or equal to 4 at baseline. So let's look at the efficacy results. It's the dual primary efficacy results. So Resmetirom achieved statistically significant results for both NASH resolution and fibrosis improvement at week 52. So when you look at the resolution of steatohepatitis and no worsening of liver fibrosis. Now, the study had 2 independent pathologists reviewing all the slides before and after. So pathologist A and pathologist B. If you look for pathologist A, what is the difference in the response rate versus placebo? 13% of patients with placebo had resolution of steatohepatitis and no worsening of liver fibrosis. 27% with 80 milligram of Resmetirom, and 36% in 100 milligrams of Resmetirom, which was statistically significant. Similarly, in pathologist B, 9% in placebo group, 26% in 80 milligram of Resmetirom, and 24% in 100 milligrams of Resmetirom. So Resmetirom achieved statistical significance for NASH resolution for both doses in a statistical analysis, incorporating both pathologists' independent readings. When you look at analysis, there was sub-analysis, there was no differences in response based on age, gender, presence or absence of type 2 diabetes, or with regard to stages F2 or F3 fibrosis. Similarly, when you look at improvement in liver fibrosis, this is an improvement in liver fibrosis without any worsening of steatohepatitis. For pathologist A, it was 15% in placebo, 23% with 80 milligrams of Resmetirom, and 28% with 100 milligrams of Resmetirom. For pathologist B, similarly, it was 13% for placebo, 23% for 80 milligrams of Resmetirom, and 24% for 100 milligrams of Resmetirom. And again, it achieved statistical significance for fibrosis improvement for both doses, incorporating both pathologists' independent readings. And again, there was no differences in response based on age, gender, presence or absence of diabetes, or fibrosis stages F2 or F3. When you look at the liver enzymes, starting at month 3 and through month 12, there was a trend of greater reductions from baseline in average ALT and AST in the Resmetirom group as compared to the placebo group. Safety profile. So next question is important thing is safety profile when we discuss with our patients. So when you look at the common adverse reactions that was reported in greater than or equal to 5% of patients in the trial, the most common were diarrhea and nausea. Diarrhea was seen in 14% of patients with placebo, 23% in 80 milligrams of Resmetirom, and 33% in 100 milligrams of Resmetirom. Nausea was 9% in placebo, 18% in 80 milligrams, and 15% in 100 milligrams. Pruritus, vomiting, constipation, abdominal pain, and dizziness were other side effects noted. When you look at these adverse reactions that led to discontinuation of the medication, in placebo there were 4 per 100 person years. 80 milligrams of Resmetirom, it was 5 per 100 person years. And with 100 milligrams of Resmetirom, it was 8 per 100 person years. Again, the most common causes of treatment discontinuation was diarrhea and nausea. So let's look into more detail regarding diarrhea and nausea. So when you talk to patients about diarrhea and nausea, if you look at the median time to an event, so how soon do they develop symptoms when you start treatment? In placebo group, it was 39 days. In 80 milligram of Resmetirom group, it was 17 days. And in 100 milligram of Resmetirom group, at a median time of 6 days, patients developed diarrhea. The median duration in which they had the symptoms. So in majority of cases, these were self-limiting. So the median duration they had symptoms was about 9 days in placebo, 20 days in 80 milligram of Resmetirom, and 20 days in 100 milligrams of Resmetirom. Similarly, for the nausea, the median time to event is 85 days in placebo, 28 days with 80 milligrams of Resmetirom, and just 5 days with 100 milligrams of Resmetirom. So if you're using 100 milligrams of Resmetirom, you can let the patient know that they can develop diarrhea and nausea early. The median duration, again, for nausea is about 17 days. For placebo, 26 for 80 milligrams and 28 for 100 milligrams of Resmetirom. And this diarrhea and nausea typically began early in treatment initiation, and they were mild to moderate in severity. Similarly, vomiting and abdominal pain were also mild to moderate in severity. Let's look at the liver tests. Increases in mean ALT and AST levels were observed in the first 4 weeks after initiating treatment with Resmetirom. In both Resmetirom dosage arms, the mean elevation in ALT and AST was less than 1.5 times baseline at 4 weeks after treatment initiation. And these values returned to baseline around 8 weeks after initiating treatment. If you look at the frequency of liver test elevations, in placebo for ALT greater than 3 times the upper limit of normal, it was 10%, 11% for 80 milligram of Resmetirom, and 13% for 100 milligrams of Resmetirom. For ALT greater than 5 times the upper limit of normal, 2% for all groups. Placebo, 80 milligrams of Resmetirom and 100 milligrams of Resmetirom. For AST greater than 3 times the upper limit of normal, it was 10% in placebo, 9% in 80 milligrams of Resmetirom, and 12% in 100 milligrams of Resmetirom. Similarly, for AST, that's more than 5 times the upper limit of normal, it was 2% for placebo, 1% for 80 milligrams, and 4% for 100 milligrams of Resmetirom. Total bilirubin, that is greater than 2 times the upper limit of normal, 2% in placebo, 1% in 80 milligrams of Resmetirom, and 3% in 100 milligrams of Resmetirom. Another important thing that we have to check is the thyroid function tests, because it is a thyroid hormone receptor beta agonist. So a decrease in pro-hormone-free T4 of mean 2% with placebo, 13% with Resmetirom 80 milligram, and 17% with Resmetirom 100 milligrams was seen at 12 months in patients treated with placebo or 80 milligrams or 100 milligrams respectively. However, there was minimal changes in the active hormone T3 or in TSH. There were no clinical findings associated with free T4 decreases. So if you look at the most recent AASLD update and what we do in clinic, the most important thing is to make sure there is a baseline TSH level and confirm the patient does not have untreated or uncontrolled thyroid disease. Once the TSH is normal and you start the patient on treatment, you want to repeat the TSH at 6 months and 12 months. So TSH at 6 months and 12 months. So it is an oral once daily dosing. And the dosing, there are 2 tablets, Resmetirom 80 milligrams and 100 milligrams, and there is also 60 milligrams, which we will talk about. But for the sake of dosing, when the body weight, it's based on the body weight. When the body weight is less than 100 kilograms, you use 80 milligrams of Resmetirom. When the body weight is more than 100 kilograms, you use 100 milligrams of Resmetirom. And let's talk about the drug interactions. And this is extremely important because we spoke about statins, and we'll speak more about statins now. When you use or concomitant use of Resmetirom with strong CYP2C8 inhibitors, gemfibrozil is not recommended. If your patient is on gemfibrozil, you cannot use Resmetirom and gemfibrozil. So strong CYP2C8 inhibitors not recommended. If you are using Resmetirom with moderate CYP2C8 inhibitors like Plavix or clopidogrel, this is extremely important because a lot of our patients with MASLD also have cardiac diseases and they may be on clopidogrel. So if they are on clopidogrel, you have to decrease the dose of Resmetirom. So if their initial dose was 80 milligrams, then you have to decrease it to 60 milligrams. If their initial dose was 100 milligrams, then you have to decrease it to 80 milligrams. So if they are on Plavix, please modify the dose of Resmetirom. Concomitant use of Resmetirom with OATP 1B1 or 1B3 inhibitors such as cyclosporin is not recommended. And we'll talk about statins in the upcoming slides in detail. The other adverse reactions, the most common adverse reactions which we spoke about are diarrhea, nausea, pruritus, vomiting, constipation, abdominal pain, and dizziness. And again, diarrhea and nausea were the most common causes of treatment discontinuation. Hypersensitivity reactions such as urticaria and rash, which may reflect drug hypersensitivity, were observed in patients receiving resmetirom. And increases in mean ALT and AST levels were observed in the first 4 weeks of initiating treatment, and the mean elevation values were less than 1.5 times baseline at 4 weeks after treatment initiation, and they returned to baseline around 8 weeks after initiating treatment. As of right now, like the ASLD said, we monitor liver enzymes at 3 months, 6 months, and 12 months after initiating resmetirom. Okay, so drug interactions, and we said we'll speak about statins. So when the patient is on statins, I look to see what statins they are on. If they are on rosuvastatin or simvastatin, if they are on rosuvastatin or simvastatin, the daily dose should be limited to 20 milligrams. So if they are on rosuvastatin or simvastatin, and if you're planning to use resmetirom, their statin dose should be at 20 milligram and not higher than 20 milligram. If they're on pravastatin or atorvastatin, then the max dose of the statin is 40 milligrams. And again, a lot of our patients have dyslipidemia, they're on statins. So if I have a patient who's on higher doses of statin, then I discuss with their primary care physician, and we have to decide on the risk of benefit of either lowering the statin or switching to a different statin before using resmetirom. So always watch for Plavix, clopidogrel. You have to modify the dosage of resmetirom. Make sure they are not on gemfibrozil, and see if they are on statins, if you need to make any changes. So regarding CYP2C8 substrates, there is a weak CYP2C8 inhibitor. So if there are any patients who are on CYP2C8 substrates, watch for any adverse reactions if resmetirom is co-administered. Use in specific populations, pregnancy, there are no available data in resmetirom use in pregnant women to evaluate for a drug-associated risk of major birth defects, miscarriage, or other adverse maternal or fetal outcomes. There are risks to the mother and fetus related to underlying NASH with liver fibrosis, such as increased risk of gestational diabetes. If you have a patient who has MASLD, unfortunately, we are seeing young women with MASLD who also have advanced fibrosis. It is important to tell them about the risks during pregnancy, like gestational diabetes or hypertensive complications, preterm birth, and postpartum hemorrhage just from MASLD. But there is no data to use resmetirom in pregnant patients. Similarly, for lactation, there is no information regarding the presence of res defra in human or animal milk, or the effects on the breastfed infant, or the effects on milk production. And the safety and effectiveness in pediatric patients has not been established. Use in specific populations like geriatric use, no overall differences in effectiveness was seen, but numerically higher incidence of adverse reactions were observed in patients greater than or equal to 65 years of age compared to younger adult patients. For renal impairment, the recommended dosage in patients with mild to moderate renal impairment is the same as in patients with normal kidney function. It has not been studied in patients with severe renal impairment. Avoid use in patients with decompensated cirrhosis. Again, extremely important. Do not use in patients with decompensated cirrhosis. Patients may come to your clinic and ask for this medication, but if they have decompensated cirrhosis, do not use this medication. Severe or moderate hepatic impairment, it increases the Cmax of resmetirom and the area under the curve, which can increase the risk of adverse reactions. No dosage adjustment is recommended for patients with mild hepatic impairment. However, the safety and effectiveness have not been established in patients with cirrhosis. So if you have any questions regarding prescription, Madrigal patient support, they are here to help you and they can answer any questions that you may have today. Once you are ready to send the prescription, it has to be sent to a specialty pharmacy network, and the specialty pharmacy will confirm insurance coverage and out-of-pocket costs. If the prior authorization is required, they will reach out to you and they will assist your office, and they will contact the patient to schedule the prescription shipment. And similarly, when it's time for a refill, the specialty pharmacy will contact the patient directly, or they may request a reauthorization form from you. You can also enroll patients by visiting the Madrigal enrollmenthcp.com form and fill out the enrollment form. There is also a copay savings program because some insurances, patients may have a very high copay, and this can help eligible commercially insured patients pay as little as $10 a month. So the key highlights of today's discussion is that Resmetirom is the first and only FDA-approved treatment for adults with non-cirrhotic NASH with moderate to advanced fibrosis. It achieved statistically significant results in both NASH resolution and fibrosis improvement at week 52. The most common adverse reactions were diarrhea, nausea, pruritus, vomiting, constipation, abdominal pain, and dizziness. It is a first-in-class thyroid hormone receptor beta agonist that works directly in the liver. It is an oral once daily dosing. Thank you.